This theme highlights the importance of accessible and equitable lung health care for every individual, regardless of their socioeconomic background or geographic location. With rapid urbanization, migrations, and lifestyle changes in India, the incidence of respiratory diseases and their economic burden will continue to rise. Efforts are required to better identify effective interventions, plan priorities, and strategically allocate funds and resources to reduce the burden of respiratory diseases. To take this forward, I request Ms. Sajna Nair, co-founder, Policy Circle, to kindly welcome our esteemed guest formally. And may I request everybody here to kindly keep your phones on silent or please switch them off for some time. Thank you.
Thank you, Lottie. Good morning, everyone. On behalf of Policy Circle, I extend a warm welcome to each and every one of you here. Today, we are proud to host the distinguished policymakers, researchers, and leading medical practitioners who will take us through the best practices, success stories, and policy measures over the next few hours. Before getting into my job of welcoming everyone, I would also like to say a few words about Policy Circle. Policy Circle is a digital platform focused on providing analysis, commentary, and research on public policy issues in India and around the world. The organization was founded in 2020 by a group of policy experts with a shared vision of promoting evidence-based policymaking. We look to bridge the gap between policy research and public policy outcomes by facilitating dialogue between policymakers, researchers, and other stakeholders. The organization seeks to promote constructive and informed debate on critical policy issues. Now, we come to the panel for today. Our chief guest, Dr. Hanumant Ayya, has graciously accepted to speak on this important public health issue. He's on his way here, so I will defer that to when he arrives. Next on the panel, on the inaugural panel, is Ms. Shailaja Chandra. She's been a career civil servant for almost 40 years, having held assignments in the central government, in the ministries of defense, power, and health. She has spent over 15 years within the health sector and was Secretary Ayush in the Government of India, and later distinguished herself as Delhi's only woman Chief Secretary. She's also a prolific writer and speaker on governance, population, health, women's issues, and traditional medicine. Very warm welcome to you, ma'am. Our chair for the first session is Dr. M.C. Mishra. He's the former director of AIIMS. His areas of interest include improving trauma care, minimally invasive surgery, surgical training, and cancer research. He's the author of over 200 national and international research papers and 4 books. Dr. Mishra is an honorary fellow of the Royal College of Surgeons, fellow of the American College of Surgeons, and a member of the French Academy of Medicine. Very warm welcome to you, sir. With that, I hand over to Lottie Alaric, who's the moderator for the day. Lottie is a distinguished television presenter, actor, and trainer. Over to you, Lottie.
Thank you, Sajna. So, without further ado, let me straight away call upon Dr. M.C. Mishra, who's agreed to chair this session, to kindly deliver his opening remarks.
Thank you, Lottie. Thank you, Anilji, Sajna, for putting up this program today. It is very apt. Winter is setting on by October, November, and we all see what happens in Delhi. The air becomes heavy, pollution all around, and there is a spurt of respiratory illnesses in children and adults, elderly, everyone. There is a lot of construction work goes on in and around NCR, so that also takes its toll. So if I can have the presentation, put up the PowerPoint. So what the topic for today's discussion, the lung diseases in post-COVID era, challenges for our country. And if we look at the disability adjusted life year lost because of various group of illnesses, naturally cardiovascular diseases top the list. And second comes mental health illnesses. Third is injury. And I just now spoke to Anilji that let's put up some program on injuries also. And then cancer, and then comes respiratory diseases in our country. Also, when we look at the years of productive life lost, so disability adjusted life year lost and years of productive life lost because of these illnesses are huge for a country like India. And it's something which consumes a lot of GDP, whether we want it or we do not want it. We do have that. Can I have the presentation on? So since we are focusing on lung diseases, this is one area which we have been discussing in post-COVID era, that there is something, short COVID is something which lasts for 4 weeks or so, and we are okay up and about, leading our normal lives. But there is an issue of long COVID which lasts beyond 4 weeks and beyond 3 months, beyond 6 months. Some symptoms do remain. And naturally, when we looked at this pandemic, it had medical and healthcare dimensions overwhelming. There were huge psychosocial impact effects which all of us have experienced. And naturally, the financial and economic impact for all of us has been enormous. The post-COVID conditions are there because it's a viral illness, so it can impact any organ within the body, right from the brain to lungs, heart, liver, kidney, musculoskeletal system. So the symptoms related to that. Now, as I mentioned, that it is a multi-organ effects of COVID-19 which last sometimes in some individuals more than 4 weeks, more than 3 months, even more than 6 months. So if we look at, this is one of the studies I encountered recently after I got policy circle information that there is going to be a seminar on this. This is from Kerala, where they looked at post-COVID conditions and respiratory. Can you have the PPT on? Don't remove that now. Respiratory system is almost 60%, and then naturally the other systems are involved. So what we were advocating during COVID era, prevent the COVID from happening in all of us as far as possible. But naturally, that was not possible by many of us, and still we contracted this illness. So the post-COVID symptom actually can impact brain. People had problems with their memory and concentration, what was called as brain fog, insomnia, depression, anxiety, dizziness, headaches, which were lasting more than anticipated, besides loss of smell and taste. Naturally, the lung conditions we are discussing today, so they actually are the main focus today, and that is rightly so, because as I showed you in that study, that respiratory system was impacted maximum in COVID. So it can lead to shortness of breath, dyspnea basically, chest pain, tightness, chronic cough, sore throat, and then there is fibrosis, which generally doesn't happen with virus illnesses, but with COVID somehow it was happening, and oxygen dependence in some individuals. So if we look at lung conditions in the same study, which was done on over 600 patients who had some, there was a district post-COVID follow-up clinic in Wayanad district in Kerala. And what they say, almost half of the patient had dyspnea, those who had post-COVID symptoms, besides other conditions. Now, if we looked at the grading of dyspnea in those individuals, it was more than 50% had none, but significant percentage, that is almost 36% had dyspnea on exertion, means they couldn't walk, and if they started walking a little bit, they had dyspnea, and dyspnea at rest was in almost 10% individuals. So who is at risk? They also determined in this study those with age more than 60 years. Naturally, it put them at higher risk of developing post-COVID persistent symptoms. Females, almost 3 times at higher risk. Severe pneumonia, if somebody was admitted to ICU, 16 times higher risk of post-COVID persistence. Hospitalization, oxygen requirement, again was associated with the pre-existing lung disease. If somebody has had some bronchial asthma or chronic obstructive pulmonary disease, was at a higher risk, almost 2.5 times higher risk. Steroid intake for those illnesses before COVID were almost 9 times higher risk of persistence of post-COVID symptoms. Comorbidities in the form of diabetes, I think many of you must have heard this, what we had, fungal infection, mucormycosis. In my life, I have not seen, generally we see 1 case a year of mucormycosis. In COVID, huge number of patients suffered with mucormycosis, and that was because of the use of steroid, indiscriminate use of steroid and heavy dose of steroid, which led to these problems. And then naturally, if somebody was smoking or consuming alcohol, they were also at a high risk of persistent of symptoms. I'll skip these slides because there are cardiac symptoms which also persist as post-COVID. And we heard and read in newspapers and papers also, scientific papers, sudden cardiac death, increased incidence of myocardial infarction, embolism, all this in cardiac myopathy, myocarditis, leading to left ventricular ejection fraction issues were also high. GI symptoms were not life-threatening in majority, and actually the loss of smell, loss of taste, GI symptoms, whenever somebody presented with that, I used to reassure, you will be fine, because most of the times they didn't have a lot of pneumonia, which actually took its toll. GI symptoms, loss of smell, loss of taste were a good sign in COVID from that perspective that their disease was milder, and they most of the time they would recover. Then naturally skin rash. So good news is the most post-COVID symptoms were amenable to nature cure. Diet, yoga, meditation, self-confidence. I think that is what had to be highlighted with most patients, and that's how most patients recovered also. Psychosocial impact was huge, and we were advocating a lot of yogic asanas, prone breathing, and counseling was helpful. And many patients I prevented personally going to hospital because everybody was in panic as soon as diagnosis of COVID was made. I'm not getting a bed and I want to go. I said, why you want to go to the hospital? You can do the same at home. Why you want to go? So they thanked me later on. But in the beginning, in wave 1, there was a lot of panic in COVID. And then psycho, neuroimmunology, and our thoughts also, emotions also affect immune system. We must realize that. So having good mental makeup, a strong mental makeup does help all of us, and continue with our yogic practice, our Ayurvedic practices. Madam is here. She was Secretary Ayush. So we advocated a lot of, and it actually helped, and I believe in that. Ayurveda is a science. We don't know, that's a different thing. But if we know that how you use this science to our advantage, I think that is where when you say challenges for India, you can overcome these challenges in many illnesses for that matter, not only. So what everybody of us should do, we must unlock our own self-healing potential, which we all have. From the beginning, we all have. If we take care of our diet, if we do some physical activity in a balanced manner, everything has to be done in a balanced manner, and follow some yogic principles, yogic secrets. Actually, if we learn and practice those, we can be much better off. So what I call in summary, our achar, our vichar, our ahar, our vihar, vyavahar, put together will make you a good human being, and it will keep you healthy also. And since we have 140 crore population, we cannot provide the same level of care to everyone. Let's prevent diseases rather than curing them, because cure will always be far-fetched for everyone at the same level. So let's prevent, and I'd say it's a very apt that this seminar and discussion has been kept by the policy circle. So stay safe, stay healthy through our own self-healing potential. And that is what will keep us healthy. Thank you so much, Lottie and Sadhna.
Thank you so much, Dr. Mishra. I think the simplicity with which he explains is really fantastic. It almost took me back to the time when we used to anchor shows. I was an anchor of a show called Healthy India, and Dr. Mishra would always come there. I have other people here. Dr. Sunila Garg would also come. Sharaja has been such a good friend and one of my favorite panelists, So all of these people have done a lot, I think, if I talk about the broadcast through these broadcast channels. So I've had the opportunity and I've been very privileged to have them on my shows for years together. So yes, Dr. Mishra, I think what you said is good, that most of it can be prevented. And yes, we are a population of such a large number, and we need to be more preventive than to actually look after cures and all that. So thank you again. And now I'd like to invite Ms. Sharida Chandra, former Secretary, Ministry of Health and Family Welfare, to kindly deliver the keynote address. The students sitting here, the medical students, I'm sure you all will benefit a great deal with a panel like this. So Ms. Chandra.
So people from the policy circle, that's Chandra and Anil and
Yeah.
Yeah. Can you hear me? Yes. So first and foremost, thanks for pulling me out of the woodwork. And Anil, in fact, greeted me as though, somebody dead had walked in. He said, "You still looking the same?" I still don't know what he expected exactly, because anyway, I'm large as life, as you can see. And definitely following all the things Dr. Mishra said about pranayam and yoga, which is definitely the best preventive and the least expensive. It has nothing to do with what I'm going to tell you, but I do feel that since he raised it and a person of his stature talked about it, it is not to be just taken as wo hamara hai. It is something which will help you and must become a part of a daily routine of everyone, every human being. It is very, very useful, and particularly for the chest and for your breathing. Anyway, I wasn't called here to speak on that, and I wanted to just pull this back to a keynote address, which is, we are in the post-COVID era. This is going to stay with us, and it'll be something where doctors, public health professionals will always be on the lookout for outbreaks and epidemics. But we as people look to governments to make policies which will we are not talking about preventing epidemics and outbreaks, that's a different subject altogether, but where we are failing to protect and prevent ill health, we do require policies which will be able to take care of that. Are we doing enough is the question I want to raise, and World Lung Day, which is on 25th, is the opportune time to reflect on everything to do with the lungs, the upper chest cavity. And there are many, many things that affect us, and we all know about them. But by focusing on something, you realize how much it affects human beings and how much it affects people living in this country, and particularly people living in this city. India itself is changing. It's not just changing in terms of its demographics. We have stabilized our population by and large, which was unheard of 20 years ago, 15 years ago, even 10 years ago. But we have reached that kind of a plateau. The past momentum will certainly continue for many years to come, but people have brought their fertility down to less than 2.1 or 2.1 itself, which was unheard of. It used to be 3, more than 3, that kind of thing. Urbanization is huge. The way people are moving from rural to urban areas is going to affect the way we live. And the economic profile of people has changed. A lot of people have moved into the middle class, which calls for a different lifestyle change. But the health burden has also changed along with what has happened. Earlier, when I was in the Ministry of Health, and I was there for donkey's years before I went to Ayush, I remember I was in charge of national programs for so many national programs for disease control. They were all communicable diseases except for blindness. And everything was geared towards communicable diseases. Nobody ever talked about non-communicable diseases. There was a Dr. Bajaj in the Planning Commission, ex-AIMS, and he used to talk about diabetes. And people used to laugh when he left the room and say, ki garib logo ka to hota nahi hai, inko kya padi hai, diabetes ki baat kar rahe hain. But the fact remains that it has now become the #1 issue because from a policy point of view, maybe we should have done something much, much earlier. We failed to do that. So all that upsurge of mosquito breeding leading to malaria, dengue, all those waterborne diseases because of sanitation, poor drinking water, all that is not over, but it has come down to almost 30%. But what has suddenly gone up to 55% is the non-communicable diseases of hypertension, cardiovascular diseases, diabetes, and chronic respiratory diseases, which has increased to more than 55%. It was never talked about at the time when I was in the health ministry in the 90s and early 2000s. And now it has become the #1 thing, but is not getting the attention that communicable diseases got because it is seen as an individual problem. It is not seen in totality. Therefore, World Lung Day is a great occasion to think over what is affecting our lives and what we can do about it. Now, #1, I would put this whole thing into 3 segments. And the first segment is controlling pollution. For protecting the health of millions, what matters the most is air quality. You may say a lot of other things are important, but if you have to look at millions of people, it is the air quality which makes a difference. And the pollution caused by burning of crop residue in the winter months, vehicular emission, construction and road dust, they're all responsible for causing severe and hazardous levels of air pollution, particularly in Delhi. And we managed to have a good AQI, as they call it. The AQI was fantastic during the G20 and unheard of for Delhi. But as Dr. Mishra said, as November comes and the Parali burning starts and many other things start, the smog and all, we will again go back not just to severe but to hazardous levels, and we will become known to be the most polluted city in the world, if not the several cities being most polluted. This affects mostly children, the elderly, and individuals who already have respiratory or cardiac problems, and they are the first groups to be affected by poor air quality. When the air quality, when AQI is high, government bodies generally encourage people to reduce physical activity, going outdoors, or even avoid going out altogether. According to the WHO survey, 1650 world cities were surveyed in August 22, the report came. Delhi was the worst of any major city in the world. Pollution also affects many NCR districts in India, having the worst and the highest death rate from chronic respiratory diseases and asthma, according to the WHO. Second, you come to behavioral factors. The prime example of this is tobacco smoking, vaping, and indiscriminately using steroids and antibiotics, which Dr. Mishra referred to. And that has become more rampant. I've done a study on unqualified medical practitioners. Today is not the day to talk about it, but Pharmacists, chemists who over the counter, even today, despite there being a ban, are selling steroids and antibiotics, which people are popping in for a day or two, leading to multi-drug resistance, and then ultimately reducing your immunity and making you succumb to a vast number of diseases because you cannot then be treated. This is the second issue, which is behavioral. Namaskar. Would you like him to speak first?
No. Please carry on.
Okay. And the second subcategory was that. The third subcategory, which I think is very important, is what happens inside the homes. And that includes burning biomass, wood, dung, crop residue. It's used for cooking and heating in most rural areas, particularly in North India, everywhere. But in North India, because the houses are closed, the tendency to inhale that is much higher. These generate smoke inside the home and contain harmful pollutants, particularly carbon monoxide, which is extremely harmful for lung health. Now, Dr. Mishra didn't say it, and I think it behoves us to talk about what are the diseases that come in the wake of having respiratory problems. Tuberculosis is certainly number one, and it accounts for about a quarter of the global, India accounts for almost a quarter of the global TB cases, which makes it a primary health concern. And this affects primarily, not always, but primarily the lungs. The next is what we all talk about, COPD, chronic obstructive pulmonary disease, which is a term used to describe chronic inflammatory lung disease that obstructs airflow from the lungs. And this is mainly caused due to tobacco smoking, exposure to indoor and outdoor pollutants, and the prevalence, as I said, in India is very high. And the third is bronchial asthma, where you have symptoms which can range from minor wheezing to life-threatening asthma attacks, which triggers, they're triggered by allergens, by cold air, by exercise, by smoke, by strong emotions even. People don't know that people who are susceptible need to be looked after, cared for, and the preventive measures have to be taken. This is also something that is lung-related in a big way. Then you have lung cancer, which Dr. Mishra referred to, and there, of course, tobacco smoking is the predominant cause, but prolonged exposure to certain types of air pollutants and indoor smoke from coal or biomass can also increase. Now, as far as smoking is concerned, it starts in our country very, very young. People do it more because of peer pressure, but the poor also have bidi smoking. They can't help it. They need something to relax, whether it's a cup of tea or it is a bidi. And therefore, in our country, the whole tobacco issue is a very highly political and emotive issue. When I was in the health ministry, I was trying to tell the then health minister, I said, sir, this is terrible that we are unable to do anything about it and we are allowing it to continue. To which his reply was, just go and meet Mr. Venkateswamy, the Minister for Labour, and try and convince him. And then I realized that Dr. Venkateswamy himself was eating gutka and talking to me. And he just laughed at what I had to say. He threw me out. So that was many years ago. After that, I must say that when I was in the health ministry, they started, I was in the health ministry, yes. They started in Delhi. Dr. Harshvardhan was the health minister, and he started this Tobacco Control Act. And we all in the ministry thought he was talking rubbish. It's not going to happen in India. Everybody smoked everywhere, in restaurants, in public transport, everywhere. We brought the law, and 25 rupees fine, 25 rupees was quite a lot of money in those days, had to be imposed by the police or by anybody who caught anybody smoking. You know, in those years when it came, 1998, it seemed before its time. It's not going to happen in India, but it has happened. So I want to give you the feeling that not everything is a basket case. If there is a political will behind it, a lot can be done. Many things are being done about vehicular emissions, and I must say those Bharat Stage 6 norms which were introduced, Government of India has been very strict about that, and they've come into effect from 1st April 23. A lot of people with older cars have had to give those cars up. That's fine. But I wouldn't say that that is going to vehicular emissions is 15% definitely, but that's not going to make a sea change. What will make a sea change, as CNG did? I was chief secretary in Delhi. I'm not taking any credit for it. I was in a supervisory position, but the Supreme Court came down and said, for 5 years, you have done nothing to phase out diesel buses. And now all you officers will go to jail. I'm starting on this. This is what the Supreme Court judge said. And I remember that I had to go to Sheila Dikshit, the then chief minister, and tell her, madam, we are not going to jail because you want to be happy with the vehicle manufacturers and with the diesel run buses. We'll have to do something effective. Otherwise, we will go to jail, and we'll be happy to say that the politicians prevented us. So she took it seriously and she said, all right, do whatever it takes. We had turmoil and chaos in Delhi. People were going in trucks. There was high going on all over the place. There were cascades on the buses were burning. We had bus bodybuilding going on in 36 different places in Delhi. Ultimately, it seemed unbelievable, and the credit must go not just to the officers, to the Indraprastha Gas Limited company, which brought the pipelines from HBJ pipeline. All this was fantastic, and we were able to ultimately to get the US Department of Energy to give us they gave us, we didn't ask for it, the International Clean Cities Award for Delhi for CNG for having the highest number of environmentally friendly buses in the world. That is the prize we got. It was possible, but now we've again gone back. And the only way that this government can change it, the Delhi government, is by bringing more and more electric buses, making it possible for people to move from cars. And I have pleaded for the last 20 years, no politician ever listens, you do need a congestion tax for Delhi. People who come into the main arteries of Delhi and clog them, there has to be, charge them 5,000 rupees a day. They will all stop using and they'll move to public transport. But here the politics comes in. You want to be happy with the automobile manufacturers, with the rich people who do not want to use public transport. They want to go in chauffeur-driven cars. And you and I also would much rather be in our own car than public transport. But metro is a shining example. Electric buses, if they take over, particularly the way Singapore has done it, you make it so exorbitantly costly. It's impossible then for people to afford to be in a car during the hours of 10 to 6. You can use it in the evenings. So the chief guest has come, and I don't want to take too much time on this issue, but I do feel that another area is road dust, which is extremely important, construction dust, which is extremely important. Governments and municipalities are doing something. We can see shields going up when construction starts. We can see pavements being a little less dusty, but nothing like what I saw in Bangkok. When I'd gone there recently, hardly 2 months ago, I found that every pavement and roads were being squirted with water religiously from 7 in the morning till 8 in the morning, which kept the dust down. We're doing no such thing. So that dust, when the Andhi comes, when the big dust storms come, that is all stuff that we inhale. It is possible to do something. We're not doing it. So having said all this to you, all that I can say is that finally, the only issues which I can raise from a policy point of view is, one, to spend more money, time on concentrated public awareness, building public awareness of the preventive side of stopping these lung infections which are going to come. Number two, it is very important to look at the totality of parali burning, the burning that goes on in Punjab and Haryana during the winter months. It is because farmers have a very small window between the end of the paddy sowing and the beginning of the kharif sowing, and they have to somehow clear the land. The only way they do it is by doing parali burning. Now, Punjab government is supposed to have gone and ordered, or is already having 1.7 lakh mechanized things for removing the residue. I don't know how far that's going to help, because that's for 3 weeks in the year. Where will all that mechanized stuff, huge machinery, where will it lie for the rest of the year? I don't know. The better thing is to change and diversify. We keep saying it, but why don't we do it? We don't do it because we are so keen to grow paddy, which is giving enormous export earnings, and we're able to export that rice. From a business and trading point of view, that is wonderful. From the point of view of health, if we don't diversify and we keep on having paddy growing, we'll keep on having this residue burning. People may get jailed and arrested and whatnot. But the fact remains, you and I will be smelling that the entire NCR and Delhi is a mess during those periods. And that totality, is export earning more important, or is the health of your population more important, is not being addressed by anybody. National Institute of Hydrology had pointed this out in a study which shows how much this is causing a problem, not from the point of view of pollution. They were on the pollution in the river Yamuna because the underground water has been drawn to such a large extent in Punjab and Haryana. And to finish what I have to say, finally, I do feel that from a policy point of view, behavioral aspects are extremely important. I talked to a few doctors whom I know before coming here, not high-powered doctors like Dr. Mishra, just the run-of-the-mill doctors who look after people who go to an OPD, and some in private, some in government. And their reaction was, do you know, most people come here with this kind of congestion, asthmatic conditions, all that. The children are already on smoking and vaping, number one. Number two, what is happening is that people do not want to confront tuberculosis and take the whole dose. They take it till they feel fine and they give it up. And the third thing that they said is that all these conditions are showing much more among women and children. If that is their view, it's not a survey, there's their reaction to the kind of people they see in the OPDs. The policy point of view is, if people are not made aware of how they can and how they must, it's essential to prevent these situations from arising. And medication and popping pills is not going to help anybody in the long run. So I've given you a little food for thought, and I hope that there's somebody, at least we have a leading member of parliament, he is listening and will do something about it. Thank you.
Thank you so much, Ms. Chandra. I think she's been known to, speak her mind, and she's given us an inside story. And the governments have been doing their part to the contrary of what people may actually think. And at the end, as she said, it is our behavioral changes that we need to put into practice. And very sadly, I think I must say that the number of women smokers in India is really going up. Mm-hmm. So we have to think about that. And it's no more cool to actually smoke. I think that is what should be, advertised, and by people who matter and by personalities, if they can say that. So it is these days, when you're with a group of people and you say that you don't smoke or you don't do drugs or whatever, like people will look at you like, oh, really? Because everybody else is doing it, and particularly in my industry, sadly. But I think the power of one, as we say, so even if each one of us starts doing that, we will see a difference, as I think she's given many examples to that. And now I'll hand over the mic to Sajna to formally introduce our chief guest for the day.
Thank you, Lottie. Our chief guest for today, it's an honor to introduce you, sir. I extend a very warm welcome to our chief guest, Dr. L. Hanumantayya, who has graciously accepted to speak on this extremely important public health issue. Dr. Hanumantayya is a member of the Rajya Sabha and a member of the Parliamentary Committee on Health and Family Welfare. He is also a member of the governing body of the Indian Council of Medical Research. Dr. Hanumantayya is also a noted poet and the recipient of several literary prizes, including the Sahitya Academy Honorary Award for Lifetime Achievement in Literature. It's an honor to have you, sir, and a very, very warm welcome. Thank you so much for coming.
Sir, may I request you to kindly deliver your inaugural address?
Honorable guests of the day, Dr. Mishra ji, Srimati Shailija Chandra, and all other distinguished guests for the public health issue which is being taken up by this organization is very, very important. Lung diseases in the post-COVID era challenges for India is the
subject to be discussed now. As already said, I am not a medical doctor. I am doctor by literature, but I am working in health committee for the last 2 terms of the parliament. So I have a lot of issues which has come up in front of the parliamentary committee, particularly during the COVID pandemic. The other major concern which we were dealing in the parliamentary committee is the affordability of cancer, which is widely spreading across the country. As for my information, it is about 12 to 13 lakh patients every year adding to the cancer infection. And the death of cancer is almost 4 to 5 lakhs a year. That is also a serious issue. Treating the disease, according to me, the more important is to stop the disease or to find out before it infect anybody, and afterwards think of treating those who cannot find out before the disease comes. So there are many issues which are causing these kind of communicable diseases. Particularly cancer is one such thing which is going on. And after COVID, lot of young people are being attacked by heart diseases. Lot of young people. At the age of 30 to 45 and even 25 to 45, the report is that the COVID, whether it is a vaccine or the COVID bacteria which is affected them, or is there any other reason, the research is still going on, but we are not in a position to find out what is the reason. That is what we have discussed last. The Indian Council for Medical Research, ICMR, the committee has also requested them to go into the details of that kind of unusual heart attacks to the youngsters of the country, across the country. The reasons are not yet known, and the research and the data collection is also going on. That is one thing. With regard to cancer, tobacco is the main issue, which is a willful practice among the Indian people. Whatever you say, whatever campaign you make, that tobacco is injurious, smoking is injurious, alcohol is injurious, we are not able to stop those practices, and people are being attacked into that. Likewise, the lung disease also, as per the public health system, it is spreading across the country. It is due to modernization and urbanization are the main reasons which we cannot stop. Across the world, urbanization is the regular process. I think in India, the people are urbanizing for so many reasons. One is their livelihood. Second, the employment opportunity in the urban areas. Third, there is no atmosphere in the villages that they can live peacefully. These are all the three important things which I have observed. So for which we have not planned all our cities, whether it is Delhi or Bengaluru or any other city across the country. Though we call it as a very planned city like New Delhi, but if you go to old Delhi, you cannot say the same thing that this is a planned city. In Bengaluru also, it was once upon a time called as a garden city. Now it has become, on many factors, garbage city, concrete city. And traffic has increased so much. For the available roads in most of the cities, and the traffic which we are facing today is almost 5 to 10 times more than what the roads capacity is there. That is one part of the problem. The other problem is the environmental issues have come up recently, and we have been observing and we have been studying those things, those environmental issues, in which health is the major issue. See, the first point is you must eradicate poverty was the priority long back in a public domain. But now, allow them to live peacefully is a very important issue. Allow the human beings on their own earning, allow them to live peacefully. That is not there. That part of the thing which is affecting the health of the people is the major concern. In that, lung disease is the recent public issue in the country. So in most of our meeting, whether it is cancer issue, whether it is other communicable diseases, I have demanded a health checkup across the country to all the people, which has not, but time to time we get different kinds of diseases and different kinds of environmental issues. And today, I think for the last 2 decades, at least climate change has become an important issue across the world. Even to the climate change, the initiatives taken, particularly in a country like India where we have 140 million population, is not sufficient. That is what the experts says. It is not sufficient. We are not able to control the public transport. On one side, we encourage all companies to grow and flourish, like car companies, automobile companies, and we want employment. The other side, we say we want employment, so these companies has to come up. In fact, I must tell you, the states are in competition to invite investments to their states. For the simple reason, they want investment, their employment generation has to reach the people. That is their concern. On the other hand, the states never ever thinks what are the environmental issues due to this kind of industrialization. See, there was a time, if you don't industrialize any country, you cannot survive. That was the idea. But today, the cities have become most intolerable. And it is not only city, even the rural areas where the agriculture is their primary job, their living has become intolerable. Living is not that easy or that safe. So we have to take a holistic approach to environmental problems, health issues, and you just cannot take a single line. Say lung disease, the only concern today, and we have to work on that. That is not the issue according to me. You have to have a health checkup to all the citizens of the country, whether he has a cancer, whether he has a lung problem, whether he has other habits. Due to other habits, he has been succumbed into so many other health diseases. That holistic approach has to be taken up. And to stop the health issues or to reduce the health issues, the other issues, as earlier speaker explained to us, see, agriculture, they have no alternative other than burning. And we have to have a research on those kind of things, how to solve the problems of the farmers. So today we may discuss lung disease is a health issue. No, it is an issue which concerns the environment of the country, environment of the people again. And health alone cannot be dealt separately. See, unless you encourage public transport, the environmental problem will not be solved. Unless you take up agriculture issues and make farmers more environmental friendly, your health issues will not be solved. So there is a holistic approach to the whole problem. See, for example, air pollution. We say lung diseases due to air pollution. I must tell you, whenever I come to Delhi, it will be very difficult for me to breathe normally. I am finding it very difficult. But in Bangalore, I have no other issues. I will be normal. So it is not my problem, it is the problem of so many people who are coming across the country to the capital. So what is to be done? Okay, Delhi alone cannot be cleaned. The air pollution of Delhi cannot be cleaned separately. It is linked with the other cities around Delhi. It is linked with the states of other states of Delhi surrounding the Delhi capital. So it is ultimately the problem of the country and problem of the world. See, there are countries where the population is less and communicable diseases are less. But I must tell you another interesting thing. During COVID, the deaths in India are less comparable to Europe and other countries like US and other countries. So what is this? Scientifically, they are more forward and highly research is going on there. Highly moderate medicines are available in these countries, but the deaths are more. We were lacking even for an oximeter. The access to oximeter in many villages were not there. They used to travel 15 to 20 kilometers to check by an oximeter. In such a country, the deaths was very less. I am talking comparatively. Probably the reason being the immunity of Indians. It is not any medicine for that matter. But even during the COVID, we have to think now. Tomorrow we don't know what kind of diseases will emerge. What kind of bacteria will come into public space due to these environmental issues. So my point is, we have to have a forethinking, control the environmental issues right now, along with the health hazards. So my serious concern today, the government has to take up a holistic approach to the whole health issues, environmental issues, climate change, and also the public health of the people of this country. I am always worried about one thing. Whenever these kinds of things happens, the most vulnerable sections are the urban poor and the rural poor. Of course, rural poor need not be used now. Almost all in the rural areas are vulnerable to these kind of hazards. So it is the necessity today. It is not only just taking up lung disease separately or single-handed. It should be a holistic approach to health issues. And I feel we all must demand. I always in my meetings of parliamentary committee demanded for a regular health checkup. Before finding out this, so many lakhs have got cancer, so many lakhs have got lung diseases, so many percentage has been attacked with so many communicable diseases. Before telling that, let us have a holistic health checkup and see that their lifespan has to be increased if it is not stopped, so that they should have a peaceful life during their stay in the world, whoever it is. So I seriously think this kind of organizations, wherever it is, in which part of the country, which part of the world, doesn't matter, taking up these kind of issues is signaling the society, signaling the governments that what is to be done. We will always think once we have been entered into a serious disease, then we will wake up and take up issues. But that is not the way. It is fine that I appreciate for that these kind of organizations has to signal the society and the government that this is the danger tomorrow and we have to wake up today and take an alarming call to solve the issue. In that perspective, I think the lung diseases challenges today is a wonderful initiative. I think a lot of doctors and experts are participating into this, and I'm happy that I have been part of this initiative, and I wish them all the success in this endeavor. And I also request the experts to give fruitful suggestions to the government and health department of the country, so that I personally assure you, whatever you recommend and the experts recommend, I will definitely take it up in the health committee and demand the government that what are the initiatives that they have to take up further for a long run. So that is what I can issue. Thank you for making me a part of this initiative. Thank you very much.
Thank you so much, Dr. Hanumanthia. I think he gave us a great insight as to what is the political will all about and what all is happening and what can be done. I think the multi-pronged approach that he's been constantly talking about, I think this is something that really requires a lot more implementation. I think there has to be, the policy makers have to think about it, and the people, the monitoring committees have to think about it. And we on our own selves, we also, as I earlier, the panelists also said that behavioral changes are very important. I think there was a very interesting observation made, Dr. Mishra and everybody, I think you would appreciate, these young deaths that we've been having. So I can talk about the film industry in this, that we've had a lot of people who went, and these were the people who were eating healthy. They were going to the gym, they were doing everything. But sadly, 90% of them was also smokers. So I think that could be one reason. That's what whenever I've had some conversations with doctors during this period, that's what they say. Because people think that since I'm eating healthy, I'm pumping iron and I'm doing every other thing, so smoking is not really going to harm me. And probably not realizing that that is probably their nail in the coffin. So that is something we'll have to think about, because youngsters are here. So I really want to reiterate this again and again, that when you go out there, you'll be doctors tomorrow, and even among your friends, I'm sure there must be many smokers out there. So you all really need to think about this very hard, because it's going to affect your fertility and whatnot. I mean, I'm not a doctor here, but whatever little knowledge that I have. So thank you so much, Dr. Hanumanthia. That was a very, very insightful conversation that you all had with all of us. Sir,
I want to make a comment.
Sure.
Sir, can you hear me?
Yes.
My name is Dr. Pandav. I spent 45 years at the All India Institute of Medical Sciences, New Delhi. I retired as a professor of public health. 2021, I got the Padma Shri Award from the Government of India for my work on iodine. I'm called the Iodine Man of India. What you said just now is a dream. It's a revolutionary statement you made, sir. If each and every individual in the country can have a health card repeated after every 6 months, that is the greatest contribution we can do to the health of the people in India, and possibly set a model for the world as well. Because India today's environment, we can think in isolation. Vasudhaiva Kutumbakam. So I would request you to take this seriously forward. In the United States of America, in Massachusetts, there's a place called Framingham. So they have a similar report on Framingham studies, been there since 1950. So for 70 years, they have been following it up. So today's criteria, indicator for success of this meeting today is translating what you said into action. And I've retired, but I'm not tired. I'm ready to be a part of this team that will set up. Thank you so much.
Thank you so much, Dr. Pandav. And now may I request the chair, Dr. M.C. Mishra, to kindly give his concluding remarks for this session.
Thank you, Lottie. I think Dr. Shelja, Ms. Shelja, I think very well highlighted the issues which later on Mr. Hanmantaya also reiterated on those points. Like we say, safe water consumption can prevent many diseases. Potable water, what we try. Same thing is for environment. But Mr. Hanmantaya, the only dubious distinction Delhi NCR has from Bangalore, Chennai, Mumbai, Kolkata, any other city, Delhi has automobiles put together Mumbai, Chennai, Kolkata. Then this Parali warning we were discussing, so main pollutant is vehicular exhaust. Although I must say that by the introduction of Delhi Metro, almost there was a sort of a record for close to 5 million people traveled on a single day. So what I sometimes imagine, if this Delhi Metro was not put in place, what would have happened to Delhi's exhaust? So that is something, of course, electric vehicles, CNG, everything will contribute. And I think every nation has gone through this phase. If you look at United Kingdom, with whatever size and population they had in 40s, 50s, people were dying of respiratory diseases because of pollution. But developed countries with limited population, with more law enforcement, strict law enforcement, were able to do. I can give you one example that road deaths in India vis-a-vis road deaths in USA. The state of trauma in USA, they have far less population than India. We have population, we all know, we are growing, 1.4 billion people. And if you are traveling, and I'm traveling on our roads in India, I have a fair chance of dying in a road crash, 1 in 5, opposed to 1 in 69 in the USA, 2 large democracies. But the problem with us is, and this was being highlighted in a recent television show where Mr. Gadkari was speaking to that anchor of that television channel, that he has not been able to fix this problem of people not following traffic rules on highways. Now we have so many highways, good highways to travel in 2 hours, Jaipur 2 hours, Dehradun 12 hours, Mumbai, this is happening. But then the downside is that unless we make laws, enforce them, which is a far cry in India, and that is the difference I notice from developed world and developing in our country about anything. We have cancer, of course, every country has cancer, but we have some good things. In our country, the incidence of every cancer is much lower than in Western countries. For example, I'll give you one example, breast cancer in women. The most common cancer in India, in USA, in Europe, Western Europe, we have incidence 30 per 100,000. In US, Western Europe, it is 140 to 160 per 100,000. Same is with lung cancer. So we are sometimes, in the name of urbanization, as you rightly said, So it has to be a holistic approach, looking at the environment also, not looking at lung disease, cardiac disease, injury. But we have to, when we have taken up some, we have to focus on that area. If I am working for injury prevention, then naturally I will talk about injury prevention. If I am working on lung disease, I will talk about lung diseases. And it is not that lung cancer doesn't happen in non-smokers. It does happen in non-smokers also. But smoking is a very strong association with lung cancer. And pollution is a huge contributor for lung diseases in children, in adults, in women, in elderly, and it is something which is alarming. And as you yourself said, when I come to Delhi, I have difficulty in breathing. When I go to Bangalore, and Bangalore is the most livable city, despite traffic woes in Bangalore, still it is the most livable city because of the air quality index of Bangalore. So I think we have a long way to go. We cannot say we do not develop. But for example, paddy, I think you brought about the paddy burning this after the crop burning. It also consumes a lot of groundwater. Paddy is a water consumption is highest in paddy growing. So that is where the government has to encourage, give incentive to farmers so that they deviate from paddy growing to some other crops which give more productivity. You consume less water, like these mota anaj we are talking about today, which is beneficial for our health, otherwise also other than gehu, etc., and also consumes less water. So I think it's a multi-project strategy, as you said, and since you are member of the health related committee, the policies have been, and like smoking, we could ban smoking, as Ms. Shalja said, that which was unthinkable. But now at least there is a law. I can tell somebody when I'm traveling in a train not to smoke. Previously, I was not able to do that because somebody will say, "Aapka kya hai? Hum pee rahe hain." So yeah, this is something. So thank you very much for your insight into it. That's why it's you're right that we cannot look lung disease, cardiac disease isolation, but we have to focus on everything. But naturally, we have to prioritize. So lung diseases are directly impacting our young population. These children who are inhaling so much pollution today, after 20 years, we will see the epidemic of lung cancer. So if we do not do anything today, we'll be facing with that problem. And that is where these awareness programs, policy, like some recommendation will be given to you at the end of this seminar. So that is why we are focusing on lung diseases, because they are on rise. Post-COVID more so, because a lot of people have suffered. And that is the reason to focus on lung diseases. Of course, policy circle has been focusing on many other ideas. Last time we were focusing on smoking. This time now lung diseases, both are interlinked. And maybe I have requested Mr. Anil to focus on injury also, because that's a huge area for us. Simple reason that 72% of automobiles on our roads are using two-wheelers, not four wheels. And they are not putting on helmets. They are not fastening it. We are not enforcing it. So there are a whole lot of issues, health issues we have to carry. Thank you so much, Lottie. And I think we are already behind. Thank you.
Thank you so much. I think we've had such a wonderful panel today, the insights that they've given us as to what has been the policies, what needs to be done and how much is done. Though, of course, the road is long, but if there is political will and if there is will of the citizens of a country, then there's nothing that cannot be achieved. So, well, on that note, I'd like to say thank you to all three of you. And now we'd like to break for about 10 minutes for a cup of tea. But make sure that you're back in 10 minutes, because as Dr. Mishra just said, we're already running a little late. So let's quickly go for a cup of tea and like.
Excuse me, I want to give a suggestion to sir. Our honorable MP has asked for a suggestion that can be taken up in a health committee. So like that, we have seen the COVID pandemic, post-COVID, we saw mucormycosis outbreak, and now we are witnessing Nipah outbreak in Kerala. So yes, because of the environmental changes and post-COVID, there has been rise in many diseases, and cancer is the priority. And we are now having a lot of cancer centers which are government funded in our country. But here I would like to make a suggestion that we must have a center of excellence excellence for infectious disease too in our country, because we do not have any such center, and there is lot of burden of infectious diseases in our country. Tuberculosis is the one, HIV is the one, but otherwise also this is only a tip of iceberg. We have lot of fungal infections, and yes, rightly said that there was some immune system that could protect India from lot of mortality. And Dr. Shukla Das has written a very beautiful research paper, and she has conducted a research on this immunological aspects of COVID. So why not we have a center of excellence for including both research, management, and prevention for infectious of diseases in our country. This is what we need for making our country more acceptable and more prepared for any future pandemic or future outbreak of in any infectious diseases. Thank you.
Thank you, Dr. Chabi. So can we quickly go for a cup of tea? Thank you. हमारे लिए तो कर रहे हैं और किसके लिए करने Can somebody just go out quickly and call them, please? Anyway. I think, shall we start the session, please? Okay. So welcome back, ladies and gentlemen, to the second session. In this session, the discussion will steer towards the challenges of lung diseases in India. So the next speaker, unfortunately, he's not with us today, but he has sent his presentation. So I'll quickly introduce him. He's Dr. G.C. Khilnani, Chairman of PSRI, Institute of Pulmonary Critical Care and Sleep Medicine. Dr. Khilnani was the head of the Department of Pulmonary Medicine and Sleep Disorders at AIIMS, New Delhi. He did his fellowship in critical care from Mount Sinai Medical School, New York. He's also the chairman of Credential Committee of Indian Society of Critical Care and Medicine and member governing body of Indian Chest Society. So can we please play his presentation? Can someone play his Dr. Khilnani is, I think, the last word on what COVID was all about. And, he's been doing so much work on that. So it will be really nice listening to what he has to say.
Good morning. Thank you very much for inviting me to this important meeting of Policy Circle, and I always appreciate the effort of the organizers in creating awareness. So I've been asked to talk about increasing cases of lung diseases, reasons and solutions. We all human beings breathe 10,000 liters of air every day, which is very important for us to get oxygen. But along with oxygen, we do get a lot of adulterating substances, which can be bacteria, which can be viruses, which can be air pollutants. With that, globally, there has been tremendous increase, as much as 39.8% respiratory diseases since the year 1990. And we are going to talk about why, how, and what can be done. There was a study conducted by Dr. Sandeep Salvi, where more than 205,000 physician visits were assessed, and it was found that 50% patients presented with respiratory symptoms. So what are the respiratory diseases which we see? Before 1950s, the chest physicians were equated to TB doctors. So TB was very common. From 1950 to 2000, asthma, COPD, pneumonia, and bronchiectasis became very common. And as we progressed, the sleep apnea, the interstitial lung disease, and COPD and swine flu, and so on and so forth came. So summarizing that COPD, asthma, tuberculosis, and lung cancer, and COVID lung disease has become very important part of human illnesses. We all see this devastation of COVID pandemic, which came like a storm, and as many as 3 crore patients required ICU care, out of which half of them required even mechanical ventilation. And with this unprecedented catastrophe, it has left a large number of people who are suffering from chronic lung disease, of which we'll be talking about. And we saw during COVID the devastating catastrophe during the second wave. So what is the magnitude of chronic respiratory disease in India, which has 18% of the world population, but 32% of disability adjusted life years are lost because of chronic respiratory diseases. As many as 8.7% of the total deaths in India is due to chronic obstructive pulmonary diseases, and prevalence of COPD has increased by as much as 29% from 1999 to 2016. Why it has happened? What is the causes? What is the cause of high burden of respiratory disease in India? We have atmospheric air pollution, which is 40% is because of the automobiles, because of industry, because of the stubble burning, and indoor air pollution is a big problem which is adding to the human health. Besides this, active and passive smoking and tobacco use adds to the chronic respiratory diseases. With that, India is world's most polluted city. And what we have seen, that Chicago studies have shown that average Indian loses 5.3 years, and as far as Delhiite is concerned, their lifespan is reduced by 11.9 years. Isn't this troubling? And we see this India Gate before Diwali and during Diwali. This is the kind of visibility is there. And during the COVID lockdown, we saw India Gate with a blue sky. That means that air pollution is absolutely man-made. And this is a lung. On your left is a healthy lung from Himachal Pradesh. And this is a Delhi lung which is absolutely charred. And no amount of treatment, including inhalers, can change it. So what is the impact of air pollution on our health? These are the Indian studies which were published by us in the international journal. There is increased premature deaths. There is increased respiratory cause of mortality. There is increased acute exacerbation of asthma and COPD and increased health expenditure. What about infections? We all know tuberculosis. It's a very important disease. As of now, 4 lakh people die of tuberculosis every year. And as many as 10.6 million people fell ill with TB in year 2021. And geographically, most TB cases in 2021 were in the region of Southeast Asia and Africa and Western Pacific area. 4 lakh people are dying every year with tuberculosis. So, lot of action plan has been taken for managing tuberculosis, and which is a preventable disease which is transmitted by droplet. The WHO aimed at end TB project by 2030 by doing a case detection and treatment and tuberculosis vaccination, but India has aimed to end TB by year 2025. So how can we do that? This is because of development in the diagnosis and treatment of tuberculosis. So what are the developments in the field of diagnosis and control of chronic respiratory diseases in India? Previously, this was the kind of stethoscope we were using, spirometry, these are the kind of ventilators. Now there are several advancements in the diagnosis of lung diseases, which includes lung function tests, which are widely available in majority of hospitals. And there are rapid diagnostic tests when TB can be diagnosed in a period of 2 hours. Not only the TB can be diagnosed, also it is possible to know about drug resistance by these biotechnological tests. So there should be a sustainable development goal. What can we do about this? The target is to reduce the premature mortality due to non-communicable diseases by 1/3, and India has a national policy to reduce 25% morbidity and mortality by the year 2025. So what is the goal as far as the respiratory disease is concerned? There should be early detection of lung diseases, control of smoking, decreased use of household solid fuel, and control of ambient air pollution. If we are able to achieve that, lot will be gained. It is deplorable as far as the COPD is concerned. While in the Western countries, more than 95% cases are because of tobacco smoking, in India, the air pollution is responsible for 50% of cases of COPD. Tobacco smoking by 25% and others, mainly occupational, mining industries, power plants, are responsible for COPD. Ironically, all are preventable. So how to reduce burden of chronic respiratory diseases in India? We have to reduce the ambient and household air pollution. The ambient air pollution can be reduced by fuels for automobiles like biomass fuel, as we have introduced CNG and now ethanol has been used. Use of electrical vehicles is a silver lining, and household air pollution can be reduced by stopping the burning of fossil fuels like coal and wood and so on and so forth. Control of tobacco smoking is also very important. Other safety measures in the mines and industries, and early diagnosis and treatment of diseases such as tuberculosis. In India, the household air pollution has been addressed by the government of India and Ujjwala Yojana, where the gas cylinders are being provided, and as many as 10 crore families had the benefit of gas cylinder. So concluding is that India suffers from disproportionately large number of chronic respiratory diseases, including tuberculosis. There has been advances in diagnostic procedure and therapeutic options. Control of outdoor and indoor pollution is key to reducing respiratory morbidity and mortality. Tobacco consumption is a big menace for all systems of body, and its control would lead to reduction in respiratory disease also. A great program of TB control is on, and we hope to attain TB Mukt Bharat soon. And control of air pollution and tobacco use require a mass movement, which required contribution not only from the policymakers and administrators, but from each individual of the society. If we do all this, we will be reducing the burden of respiratory diseases, which leads to preventable morbidity and mortality. I once again thank you all, and with the last word, which Mahatma Gandhi, our father of the nation, said, the difference between what we do and what we are capable of doing would suffice to solve most of the world's problems. And this couldn't apply more with chronic respiratory diseases. We know how to prevent it. We know what it causes. If we do what our knowledge says, we'll able to reduce the chronic respiratory diseases to large extent. With that, I thank the organizers and I thank you all for the kind attention. Thank you very much.
Well, so that was Dr. Khilnani, and I think he spoke extensively upon the practical problems that we are facing and how we can tackle them. Well, moving ahead, we have with us Dr. Madan Gopal, who's currently the Advisor, Public Health Administration, NHRC, Ministry of Health and Family Welfare, Government of India. He was also a senior consultant at Niti Aayog. Dr. Gopal is a public health professional with more than 30 years of experience in working on issues related to health system reforms. He's passionate about driving innovations and building sustainable health systems for better health in India. Well, so Dr. Gopal, today he will be sharing with us the steps that the government plans to take in addressing the rising caseload of lung diseases. Dr. Madan Gopal, please.
Thank you, Loto, and thank you, Policy Circle, for once again inviting me and sharing my views and observation. Hope this time it won't bounce back on me. The last time when I did a tobacco thing, it bounced on me and we have managed it. No issues. That's one thing. Second thing, in the morning session, when we heard about the lung disease, I just want to start. How many of us are aware about our lungs? I think the answer would be no. Till the time we had some respiratory ailment, we don't feel we are breathing. We don't, what we are respiring, we don't know. We are not aware about that. Unless you are a yogic person and daily do pranayama and other thing, then you would be aware about what you are breathing. It's all autonomous. Automatic things happen unless it is infected. The second example is if you are, I'm a survivor of Bhopal gas tragedy. I know what lungs are and how lungs are important to your body. That's another thing. And most of us, we are all COVID survivors because the Omicron virus has touched the lives of everybody. So it has not spared anyone, either clinical, subclinical. That's why the maximum things have happened. During the first wave, when the thing started, we were all having experience of SARS and MERS. As a result, we were very much skeptical of what we would be doing when this COVID comes. And there were a lot of things, how to protect the lungs. A lot of discussions and other things have happened. I'm trying to just emphasize on the importance of the lungs and why it is very important. Because unless we become aware about the lungs, it's all just as a routine we are talking about. We have to protect on the World Lungs Day. We have to be aware about the lungs in our day-to-day things. Both respiration is not left to us. If the higher conscious, if that's left respiration to us, we would be only taking breath as and when required. You see the consequences of that. We are very conscious about the fact, and I would be just highlighting what the government has been doing about that's a question which Loto has asked me. I would be sharing what updates are happening. Before starting, I thought that I should be sharing this observation so that everybody becomes aware what lung plays in our day-to-day life. Till the time you, as mentioned by the previous speakers in the inaugural session, everybody is healthy, they are pumping iron, but they are not aware about the lung, what is a healthy lung, which whatever lung they are having, they usually smoke and they don't take care of that. The students are there, you see that if you are having respiratory ailment, you don't bother to take care whether the infection from your throat will go to the lungs or not. You just continue working till the time it inflames your alveoli and it symptoms of pneumonitis and other things comes up and you have to land it to an hospital. So that's why awareness about the lung things happen and we are very much conscious of the fact. And COPD is one of the leading cause of death in the country. It is affecting as we are having I think triple burden of disease. One is communicable, non-communicable, and the third the RCH burden of. We can't say burden of disease, but RCH problem is there. Another thing is been added is the emergency and the traumas, which have now become the fourth burden. We have to handle that. We are conscious about the fact that we are seeing that how the things are moving and what the government and other things. They are very conscious of the fact that this are the 4 areas where all work has to happen. If you look at the programs, we have a national program for non-communicable disease, which have guidelines for respiratory ailments and the chronic obstructive pulmonary disease. In this program, we have created a network of public institutions. We are trying to rope in the private also. If you look at the biggest public-private partnership which the government is having, which would be addressing the COPD and other cases, is your PMJ program or any of the health insurance schemes that the state governments are having. That's another initiative which is there. That means we are very much conscious of the curing or the treatment part of this people getting lung infections. That's one thing. The other program which my previous speaker had mentioned, that's a national TB elimination program. We have preponed the SDG commitments and we are trying to see that how we can reach the elimination goal by 2025. Many things have happened in the TB elimination. We are moving in to a path towards elimination. Let's see that how we do that. In the rural areas also, many initiatives are happening. That the SARS program is there to raise awareness about the rural population. Then apart from that, if you look at the tobacco and other thing, that's a different altogether. But we do have an anti-smoking laws. The vaping is also banned in the country, but still people, they vape. And they have been, the moment the government starts banning the tobacco, the repercussions which I had around 40 complaints made. So for what? Because I am a public health person. When I'm seeing a public health problem, I need to raise that issue and see that what are the effective steps which need to be taken. That's one thing, but that will not resist me. But as a public health professional, whatever in the interest of the public we can do, we could do it. The anti-smoking, slowly and slowly now, as mentioned by Mishra ji, that previously you would have during the break, you would have seen 5-6 people from the faculty or the audience going out and smoking. Now this time, fortunately, we have not seen anybody going out and smoking. During the meetings also, we would have seen, after 5 years back, you would have seen people, they are going out for a nicotine break. They used to say, and they used to relish also think that we are going for a nicotine break. That's one thing. That from the efforts which have been made, at least that kind of awareness and that kind of change, behavioral change is happening. And behavior change, remember, is very difficult to address. We can inform the person, we can raise awareness, but to translate that awareness into behavior change, it takes time. And efforts are being made in that direction. On the infrastructure also, we do have an infrastructure. Public infrastructure is very, it's a more or less systemic way. We have expanded it. You name, we have reached up to a population of 3,000 to 5,000, where we are having an institution. But before that, I will just say that we have sailed a journey from disease to health, from health to wellness, from wellness to well-being. That kind of paradigm shift is happening in our way of thinking. Previously, all the things are focusing on disease. Now, after disease, we have started talking about health. We had the mandate that the health for all was there, then the Millennium Development Goals were there, then the Sustainable Development Goals are there. Now, to achieve that thing, many efforts have been made. One of the vehicles for making a change for achieving the Millennium Development Goals for the National Rural Health Mission, which subsequently became NHM. Now we have to address the issue of reaching the Sustainable Development Goals, for which now we are adding more intense mechanisms to do that. We do have National Health Mission, which is more done in a renewed way. Second thing is your Ayushman Bhav program, which is having 4 pillars. One is for the comprehensive health coverage. Previously, the strategy was the primary health care strategy. Now we are having a comprehensive primary care health strategy, wherein we, instead of assuring that the lowest most institution which I mentioned, that is at the 3,000 population, from there previously we used to give an assurance of 6 services. Now we are giving an assurance of 12 services, including the wellness part. That means wellness for yoga, wellness for pranayam, and wellness for this. That means from that level, we are trying to see and address and see that the people become healthy from that angle. So the government is aware and we are making strides in that direction. And that institution is now upgraded and known as health and wellness centers. Through that, the wellness component is basically aimed at bringing in yoga and other things into the day-to-day practice. That means at the population, which serves to around 5 to 6 villages, we have been trying to address this wellness component there. Then above them is a primary health center where you can have the treatment of the primary ailments, and then we do have the community health center. Then above that, the district hospital, and most of the district hospitals now, there's a plan that all the districts would be having one medical college. We have always been talking about the board committee, which envisaged to have 2,000 bedded hospital at the community development block. But instead of that, but to realize whatever was the thought process during 1940s, we are making strides in that direction. Now we do have at the block public health level, we are having a block public health unit would be taking care of the other aspect, infectious disease aspect and the other aspects. Then there are other efforts also. So we are not only focusing on health. Now we do have some efforts and the mechanism in which we are trying to address the social determinants of health. If you talk about the national health policy, apart from providing support to health system strengthening, we are trying to address the social determinants of health also. So as Dr. Khilnani ji has mentioned that the Ujjwala Yojana, because smokeless previously that before the Ujjwala Yojana, if you go to any rural household, you would be just, if you being from the community medicine side, if we go to the village for doing some household survey or you want to interact with the person, then unless if the person is cooking there during that time, then unless you are used to the smoke, you won't be able to enter the house. Now that situation has been taken care. The second thing is during the COVID time, you have seen that the housing was the biggest challenge in the urban areas. Apart from that, the urban population is growing. And yesterday we have been released a draft NUHM 2023 framework. This talks about how to deal with the environment, talking about health in all aspects. That means if you are planning for traffic, you have to talk about health, how you are able to take care of the health aspects of the people. If you are trying to talk about sanitation, you have to talk about health there also. If you are talking about air and the air pollution, you have to see that how these factors have been placed. That NUHM 23 framework would be more or less reflecting on that. That is available on this. Yesterday, there was a conclave and we could release the draft guidelines for this. That's one thing. Other thing is the Swachhata Abhiyan and other thing. In the urban areas, I was talking about the densely populated and the housing is a problem there. In this housing, what we are doing, you see that the focus of the PM Awas Yojana, which is there, so it is at least to have a area so that the density of the population at least can be dispersed and distributed. Otherwise, it would be challenging for lung disease if a densely populated area is there. You see that. If you see the sanatorias in the hilly terrains, in Uttarakhand, you have a lot of sanitarias, Himachal sanitaria. The population which is coming and utilizing that sanatoria, though the sanatoria concept is more or less getting obsolete, but still it is there. Recently, I have visited there. I could find 60 people undergoing TB treatment, all for hemoptysis and complications. That sanatoria are there, many dignitaries, they have also got treatment there. So that kind of mechanism is there, but we have to see that how we address that issue of housing so that the densely populated area and the government is having a Awas Yojana and other in one way or the other. The other thing is smart cities wherein they are promoting the wellness component more. They do have built in the smart components into that. Then the framework which I've already mentioned. These are many of the initiatives which are happening, but the individual needs to be made aware that he has to protect his lung and take care of it. Unless we will only become aware when we are having some ailment, otherwise we are not aware, because many of the body ailments are not aware till you either by your yogic experience you become aware about that, or if a disease happens, then only you are aware about that. I will stop here. So thank you very much for this.
Thank you so much, Dr. Madan Gopal, for talking about the initiatives that the government is taking. And it's good to know that we've moved from disease to treating the disease to wellness. I think this is the need of the hour. The wellness part, I think many in the private sector, of course, is talked about a lot, but it's nice. I think government is also focusing on the same now. So thank you so much. And now we have with us Dr. Aparna Mukherjee. Let me just give you a quick brief about who Dr. Aparna Mukherjee is. She's a senior scientist and in charge of clinical studies, trials and projection unit at Epidemiology and Communicable Diseases Division, Indian Council of Medical Research, New Delhi. She was awarded a PhD in pediatrics by AIIMS Delhi and has presented several research works in national and international conferences on pediatric pulmonology, pediatric infectious diseases, tuberculosis, HIV, clinical trial, COVID-19. Dr. Mukherjee is also the recipient of the prestigious Early Career Fellowship of the Wellcome Trust India Alliance. So Dr. Mukherjee today will be talking about the latest scientific advancements in the field of pulmonology, global best practices. So over to you, Dr. Aparna.
Thank you for inviting me here, and we have a very young audience today. So hopefully we will be able to give some impressions which you can carry forward in your work life and in your further career. I did have a presentation. Yeah. This is just a placeholder. So what we have been hearing is about the respiratory pathogens. Like I'm basically an infectious disease person. So apart from the non-communicable disease that ails lungs, there is also a huge burden of respiratory pathogens in our country, and these have pandemic potential. That is why we are worried about them, as we saw with COVID-19, how it completely devastated the whole of the country, and we are still having some lingering effect in terms of dyspnea, in terms of fatigue, etc. But COVID-19 did teach us a lot of things. I'll mainly focus my talk as to how it impacted clinical research, because a lot of these advancements that we talk about need to be backed by evidence. And that is where our job comes in, to generate that evidence so that the policymakers, the government is confident enough to actually implement those on a large scale. So what we saw during COVID-19, we had a very unusual situation where initially the country was in lockdown, there was problem in movement. And even after that, in clinical research, the most important point is the patient, is the participant. So we did find that during COVID, there was a huge reluctance to participate in clinical research, partly because people were wary in coming to hospitals, in actually visiting any healthcare facility, and they were right to be worried about it. And so it was difficult to recruit people. And as such, all the hospitals were overburdened at that point. All healthcare workers were taking care of patients in any form. So it was very difficult to get people to work for research. But at the same time, it was important that we generate evidence, because it was a complete new disease, which we did not know anything about. Unless we have evidence, it was all empirical treatment. So we were facing a very, very unique situation where usually where we do a trial, we do a clinical research, it takes its own, sweet time to get the preparations done, to get the approvals done, and then the study done. But here we were all racing against time, so that we had to get it done in a very fast forward way, and we had to get answers before the whole thing became combustive. So what we actually found was, since we did not have answers, there were so many studies taking place. Like if you go to the Clinical Trial Registry of India, I'm sure you're aware of CTR, right? There's a registry where you can and you have to register all your trials before you start them. So that is a very good resource where you can know what are the types of studies that are being undertaken in the country. So what you can see is that there were multiple single center studies, because everybody was looking for answers, and they were taking up resource in both terms of money, in terms of manpower. But then if you have smaller studies and multiple of them not well designed, they were not actually providing the answers that people were looking for. So this led to the discussion around the globe regarding research waste or inefficiency of research, as we are calling it, in which in all good intention, everybody is doing studies, but they are so fragmented or in silos that they are not actually leading to anything conclusive, any definite answers. So, what are the lessons that we learned from this whole scenario? One is that we need to reduce this inefficiency. And for that, we need to have more multi-site collaborative studies. And we did see that in times of emergency, collaborations do happen. There was a lot of data sharing, technology transfer, not only amongst national institutes, national bodies, but also amongst international institutes and international bodies. And that is how people could come up with vaccines, could come up with some definitive treatment. So if we could do it during emergencies, during a pandemic, why can't we do it during the other times as well? So that is why we need well-designed collaborative studies, which would be representative of a larger population, which will be more definitive in its question and will answer the question that we are asking. And we don't need to repeat the same study again and again. They have to be well-designed, conducted with rigor. So this is what everybody understood. And another important thing that we understood is that there is a need for ready networks, need for ready centers which know how to do these studies, and they can be, incorporated in any study as and when needed. Because if you start from scratch, try to train people as to how to do it, it's going to take time. But in a situation where you need answers easily and quickly, trial networks are a boon. So that is something that we realized we lack in our country. Each of our senior researchers might have their own network of people with whom they do work all the time, but there is no such network which is there and which is being trained, capacity building is being done, and which can be utilized in terms of pandemic. And as you know, we also learned that we need some kind of newer designs to do our study, which can be done faster. We need master protocols. We need new approaches. If you have been doing clinical research, you would be aware that there is a lot of things like monitoring and visits and a lot of paperwork and consent. All these are involved. In times of the pandemic, in terms of these monitoring, a lot of innovative ways were used. Like we were having VCs in order to monitor. Remote monitoring became a thing, and it was very efficiently used by all investigators. As the patients did not want to come to the hospital, they did not want to follow up with healthcare visits. So therefore, video calls or phone visits became the norm, where a very elaborate history could be taken from there. E-consent was a norm. And then comes the question of actually building the research ecosystem. Unless you build the research ecosystem in times of peace, it's not going to give you the benefits in times of emergency. So that involves ethics reviews. Many of you might be members of ethics committee, or you have undergone reviews by the ethics committee. And what we realized is there is still a huge need to sensitize our ethics committee to be able to do the review in a faster manner, in a more comprehensive manner. And embedding these practices in our routine practice not only elevates the routine clinical practice, but obviously helps us in finding answers. This we already talked about, that we realized a network is needed because that gives us a wider representation, that gives us a way to do faster enrollment and an access to higher number of willing participants, and more number of investigators can be involved. Because as we know right now, clinical research in our country is carried out only by few institutes of national importances, And majority of our studies, our publications, everything comes from these centers. But there's a whole wide array of medical colleges and investigators who have good ideas and who have access to the patients who need these treatments. So that is where a network comes in, and Indian Council of Medical Research has launched this network, which is across the country, which involves more than 40 centers, and it is an ever-growing network. During COVID, we did conduct a few studies from which we actually, we could glean these lessons, these barriers that we faced. But still, even during that time, we had these, ways to solve these problems so that we can get proper data. And I was told to talk about best practices. So we did have some very successful examples of collaborative research across the world. You all have heard about the recovery trial, which gave us the first definitive treatment. Like people were using, our clinical colleagues can tell us people were using steroids, but then this gave us evidence that yes, dexamethasone is helpful in people who are requiring the oxygen and ventilatory support. Then we also saw pivoting of already existing collaborations. NIH has a huge network of collaboration, which was built during the HIV times, and they pivoted it in order to answer the COVID questions. So that is another way that we can solve our problems of having centers to do research, ready centers. Recently, WHO has come up with a draft clinical trial guidance, which talks about, again, collaborative research, participatory research, because most of the times we see collaboration from high-income countries where they have a protocol, they come to us and we're just centers providing them with samples and patients, and we don't have so much of intellectual input in those studies. But then now, people have realized that if you really want to tap into the potentials of all the low-resource countries, you have to have more of a participatory discussion rather than just a colonial way of exchanging ideas. And as I said, research ecosystem development is very important, and we are working towards it so that we have a more robust ecosystem where interested investigators can do their work properly. Thank you.
Thank you so much, Dr. Mukherjee, for giving us a detailed account as to what all has been happening and what the future really entails for all of us. And now we are delighted that we are joined by Dr. Peter Harper, from the founder, London Oncology Clinic from UK. So are we connected to him? Yes. So I'd like to welcome Dr. Harper. So a quick word about who Dr. Harper is. Dr. Peter Harper has been a leading consultant at Guy's and St. Thomas Hospital for over 25 years. He's both an accredited physician and a medical oncologist. He's also one of the 4 founding partners of the London Oncology Clinic. He's acknowledged globally for his work in researching new drugs and developing innovative cancer treatment. He's currently a member of 8 pharmaceutical company advisory boards and is a member of 16 professional bodies from around the world, including board membership of a committee of the American Society of Clinical Oncologists. In 2002, he was awarded the prestigious Sino del Duca Medal in 2004 in recognition of his work in developing new anti-cancer and vaccine therapies. For his role in advising the French government in strategic cancer care, he was appointed a Chevalier of the Légion d'Honneur, a rare distinction for a foreign national. So Dr. Peter Harper will now be talking about global best practices in tobacco regulation and a critique of Indian policy. So Dr. Harper, welcome to this seminar, please, and over to you, sir.
Thank you. Can you hear me?
Yes, sir.
Oh, good. Thank you. So what a great pleasure to be with Policy Circle. And thank you very much to the last speakers. I've been listening to you. And I'm very well aware of India. I was fortunately on the board of Max Hospitals for a number of years, and I've been coming since I was 20 to India. I came as a medical student as part of my elective. So you're part of my love affair. So I'm talking about today newer paradigms, tobacco harm reduction. I want to just go forward and show you that I was an oncologist for all my working life at Guy's. I was one of the very early oncologists, and I took on lung cancer very early on when the dominant tumor type was small cell lung cancer, which had an absolutely miserable outcome. So from the earliest days, I've tried to encourage quitting, but I've also understood quite clearly that it's difficult. So this is my disclosures, several pharma companies, which we always are, and we do a lot of clinical trials. I've published well over 300 papers on clinical trials. I'm a harm reduction consultant to Philip Morris, and the reason I'm doing that is because I've moved to trying to prevent cancer from having to treat cancer with such a miserable outcome and a huge expense. So when you want to reduce the risk of a lung cancer or any cancer, you have to identify the nature of the production and the exposure to the source of the carcinogens. Well, it's not difficult in lung cancer. As you can see here, men, 90% of lung cancers are associated with smoking, and in women, 80% of lung cancer is associated with smoking. And of course, the reason was, as quoted by Professor Gopal, is of course pollution within the home. So why? Well, this tells you that 64% of smokers who've developed lung cancer continue to smoke. And it was this fact which really has pushed me to trying to understand smoke and the carcinogens in smoke. Because when you've got lung cancer, surely to goodness, you will stop smoking. There's every evidence that if you do so, your prognosis is better. Not by much, but definitely better. Nevertheless, you cannot quit smoking. You're under stress and it's impossible. So what you've got is a huge group of people who are unable or unwilling to quit. Unable means they can't, they're addicted. Unwilling means they don't want to. We know, and all of us know, that if you don't change the number of smokers, you'll not change the number of cancers, and you will not change the number of chronic respiratory disease. So what happens if we as a population, we as policy directors, we as doctors fail or refuse to innovate? So where we are is we've got a problem. What can we do? Well, we can just treat the problem, or we can try and do something about the root cause. So you've got left 1 billion smokers in the world, of which 100 million are within India. 80 million lung cancers, 8% of smokers will develop lung cancer, and I'm not talking about bronchitis, and I'm not talking about bladder cancer, and I'm not talking about kidney cancer, and I'm not talking about esophagogastric cancer or mouth cancer. I'm talking about lung cancer. 8% of smokers will develop lung cancer, and that will result in 64 million lung cancer deaths. Now, no nation can afford the new innovative treatments for cancer. Though you have a great industry at making generics, it is still a vast price. So the cancer risk factors in India, if you look at 1990, and then you look 30 years later, what you see is smoking is number 1, and chewing tobacco is number 4. So we don't need to look too much further as to what is the first thing we should do. Yes, you've got to address pollution, and there's no doubt that pollution will compound the risk of cancers. So what is the concept of harm reduction? And I founded a society long ago, now got 8,000 members, on harm reduction. The whole concept is that we accept that people have behavioral issues and we deal with them. We deal with it in the UK with a fair skin. You use sunscreen. We deal with it in motor cars, where we put in airbags, we put in crumple zones, we put in disc brakes, we put in steering columns that don't crush your chest. So we know that we have to reduce harm. The concept really started by reducing the harm during the time of drug addiction and HIV. It was a massive issue, came very fast. We introduced safe zones for people injecting, and though it was illegal, we gave clean needles and clean syringes. So harm reduction saves lives. Now, the huge misconception, which has been around for many years, is that nicotine is the cause of cancer. Of course, nicotine is the cause of addiction. It is not the cause of cancer. Nicotine is not a carcinogen, and nicotine replacement therapy has been used for many decades by doctors to try and help smoking reduction. But what are the innovations that we should look at? And the first of these is snus. Then I will go on to vaping and e-cigarettes, and then heated tobacco products. Snus is an oral tobacco. Now, we know in India that oral tobacco, chewing tobacco, is a disaster. Snus is a very different tobacco. It has no heavy metals, and it is pasteurized. It's in a little tiny sack, which you put behind your lower lip, and it gives you nicotine, but you don't combust. Now, the blue line here is male smokers in Sweden in 1963, 50% of the population. What you can see is something dramatic has happened. And what was dramatic was the introduction of snus. And what you can see is as snus went up, smoking rates dropped by 30% by 1986 and have continued down. This is female smokers. They picked up snus later. And as you can see, as their snus rate went up, their smoking rates are down. So what you can see is that you've converted someone from combustion to a safer method. Now, why is it safer? Well, if you look here, death rate per 100,000 males attributable to tobacco, not cancer, all causes of death: lung disease, cardiovascular disease, vascular disease, and cancer. And this is the rate attributed now in the current years to these tobacco-related diseases in Sweden. And what you can see is they've got a rate of 152. The green line down here is 373. That's the European average, so it's twice. And if you come down to here with Hungary, it is a quarter. So this enabled the Federal Food and Drug Association to look at what was the cause of this reduced risk. And they said, well, it seems to work. And they issued a modified risk tobacco product order. And they said using general snus instead of cigarettes puts you at a lower risk of mouth cancer, a lower risk of heart disease, a lower risk of lung cancer, of stroke, emphysema, and bronchitis. So that was a pretty good review. Public Health England, of which I've been part, says harm reduction is saving lives. And here, of course, we have a population only of now 60 million, compared to your 1.3 billion. Every minute, someone is admitted to hospital from smoking, with around 79,000 deaths a year in England alone. Our new review reinforced the findings that vaping was a fraction of the risk of smoking, at least 95% less harmful. Very few people know that. And of negligible risk to bystanders. So if you're by somebody who's vaping, you don't get any toxicants. Yet over half of smokers either falsely believe that vaping is as harmful as smoking or just don't know. Reducing the prevalence of smoking by 1 percentage point each year for 10 years would save in the UK, with our smaller population, 69,000 deaths. And the important thing is these are deaths between 35 and 74. It's not an old person's disease. It would be tragic if thousands of smokers who could quit with the help of an e-cigarette were being put off by false fears of their safety. As we can see, we're now down here in the UK, we're down to 11.5% of tobacco smokers, a huge difference. Now, what else is there? Well, there's heat, and I'll explain what a heated cigarette is compared to a vape. But what you can see here is the difference on a smoking machine on a test filter paper of what is cigarette smoke, one cigarette, and what happens if you use a heated cigarette. And this cream color is, of course, largely water and glycerol. This, of course, is what we were hearing earlier is going into your lungs, whether due to pollution, whether due to tobacco, or whether due to both. Now, what is the science of combustion? What we know is if you heat the cigarette, you do not combust, no burning, you do not light it. Very few toxicants come out before the temperature of 350 degrees or 400 degrees. This is what happens when you combust. You get this outpouring of carcinogens. As the temperature rises, and the temperature of a cigarette will go up, a tip will go up to 800 degrees, and there you get ash, everything's burnt. You get this outpouring of carcinogens. This is shown pictorially here, and this was, again, the Food and Drug Association of America, independently looking at one product, which is IQOS. And they said they guarantee there's no combustion in the IQOS. It does not burn. It reduces levels of toxicants compared to cigarettes. Smokers who switch completely to IQOS, still getting the nicotine, will reduce their exposure to toxicants. It's got a much lower toxic potential than cigarettes. And though you can't prove yet that this will reduce the rate of cancers, it's highly likely that it will do so because the carcinogens are fewer. Now, what we can see is what happened in cigarette sales in Japan with the introduction of, in this case, a heated tobacco product, IQOS. This was the number of 200 billion cigarettes sold a year in Japan, and something happened precipitously to reduce that level. And what happened was the introduction of nicotine in a different way, IQOS. And what you can see on the orange line is IQOS sales, and this is total sales. Now, the important thing is that if you add the IQOS to the previous cigarettes sales in terms of tobacco, you can see there's still a marked reduction. You are not increasing the number of tobacco users. This is Japan, and what you can see here is this precipitous drop in tobacco combustion, cigarette smoking, over a period of 6 years after the introduction of a heated tobacco product. You've gone from 19% to 13%. Same thing happened in New Zealand, but with vaping as well. Same thing happened in the UK with vaping as well. Australia has banned any form of nicotine other than a cigarette, and it is stuck. It cannot reduce its rate. So Public Health England then looked at youth use and quit smoking use, and it came to the following conclusions. Experimentation with e-cigarettes has steadily increased. Regular use remains low, with 1.7% of 11 to 18-year-olds using it regularly. Vaping considers to be associated with smoking. Those who were smoking will both vape and smoke. The proportion who never smoked who use an electronic cigarette at least weekly remains very low. So we don't think we are introducing nicotine and smoking into the population. Quit smoking cigarettes, combining e-cigarettes with stop smoking services does seem to be having an effect and a good effect. And so we continue with Public Health England to agree that we should introduce both vaping and heats in the UK in order to help reduce tobacco smoking. So the conclusion is smoking is a major issue in public health and a leading cause of cancer. Quitting is by far the best option, but we realize with 64% of patients with lung cancer unable to quit, it's a very difficult thing to do. Current strategies have failed. We really haven't reduced numbers. Prevalence continues to improve because of your increased population, but the actual numbers of smokers hasn't changed. You need the whole story to understand the success or failure of your policy. And my belief is that we need new solutions. And I've tried to outline the reasons for that. Thank you.
Thank you so much, Dr. Harper, for that detailed account that you gave us and the real picture, the comparisons that you gave of many countries and how when policies are put to use, human behavior can change. So I think that was very, very encouraging. Thank you so much for taking time out and for joining us here, Dr. Harper.
Thank you.
Moving ahead, we have with us Dr. Chavi Gupta, the next speaker. Well, a little bit about Dr. Chavi Gupta. She's an infectious disease specialist with experience in both government and corporate healthcare institutions. With a clinical experience and microbiology background, she's actively involved in teaching and research work. Immunology and understanding host-pathogen interaction are her key research areas. So Dr. Chavi Gupta today will be talking about the role of private sector in tackling the rise in lung diseases. So we have for you, ladies and gentlemen, Dr. Chavi Gupta.
Thank you. May I have a presentation, please? Slideshow. Yeah, excuse me. So I have been given a topic, role of private sector in tackling lung disease. So as we know that private sector is a very large healthcare sector with almost 60% of health expenditure coming from the private sector. And this sector includes big corporate hospitals, medium, small nursing homes, individual practitioner clinics. Now there is a concept of polyclinics, and new addition is the telemedicine via various platforms like Practo, and home-based healthcare is another new addition post-COVID, which has gained a lot of momentum in providing home-based healthcare to, especially to the elderly patients. So this sector caters to large segment of population, and it is a first point of contact for large number of patients, including rich, poor, urban or rural segments. And people are more inclined toward the private sector because of the perception. They have their own individual perception of better quality treatment, shorter waiting period, thus averting loss of wages, ease of access to diagnostic with short turnaround time, less documentation and immediate treatment. Here, I am not promoting any private sector. It's just that I have been given the topic, so I'm just highlighting you how the private sector can also play a major role in your public health programs. So this national health policy has now taken an objective to align the growth of private healthcare with public health goals, with reliance on the strategic purchasing. And NITI Aayog also announced public-private partnership model to link new and existing private medical colleges with functional district hospitals. So moving together with the private sector to expand access to care is the main goal. So now we have our TB Mukt Bharat Abhiyan launched by our Honorable Prime Minister with the goal to eliminate TB by 2025. And TB Mukt Bharat Abhiyan is a very beautiful concept where the private-public partnership has cropped, and to take a challenge that how we can involve private sector in defeating this disease. The idea is to detect, treat, build and prevent. So public-private partnership has already been done in this segment of the communicable disease. where the public-private interface agencies were involved in engaging private healthcare providers on behalf of National TB program. So there is a program called JEET, that is a joint efforts to eliminate tuberculosis, where your JEET coordinators coordinate with the private practitioners and your hospitals to provide high quality diagnostic, to report confirmed TB patients to the program, to provide patients with anti-tuberculosis drug and necessary support for adherence to treatment. And now there is a mandatory protocol for every private practitioner to enter the data of a TB patient in the Nikshay portal, so that the government can track the number of cases and they monitor their drug treatment and follow up. And now recently, for drug resistant tuberculosis program, private sectors and bigger hospitals have taken a challenge that they will provide a treatment to them according to the national policies, and there is some memorandum how these hospitals are to proceed with such patients. So initially the target was 1 million plus private sector TB notification in the year 2020 and 21, and as per the analysis between 2012 and 2018, 47% of TB notifications were from the individual clinics, 48% from the private hospitals or medical colleges, and 5% from the pharmacists. But yet, more stringent and regulation is required in this aspect, because many practitioners are still not reporting TB to the government programs. So this is the Kerala government initiative, where they have taken a comprehensive tuberculosis program and among the private partner, your public-private partnership model. So they have created a STEPS, which is a single window system in a private hospital, ensuring all public health actions to all. Private hospital consortium was set, where there is a consortium of the hospital managements, how they will establish the STEP program, policy support review, and coalition of the professional medical associations. So STEP is the system for TB elimination in the private sector. So all TB patients, once reaches to the hospital, they get a single window for the notification, then guidance and linkage with your JEET partners, and through which the patient gets treatment and diagnostics free of cost. Now, leveraging lessons from the COVID-19 pandemic. COVID-19, as we all know, when it arrived, when it touched our country, nobody was aware what will be the disease, and we were not prepared at all. But COVID crisis may be looked upon as a historic opportunity for reimagining your public health system, as well as engagement with the private healthcare, moving to majorly expand public health services and to socially re-embed private providers. So in the initial phase of the pandemic, private sector was showing non-uniform response. They were not ready to take up the patients, and they were not actually prepared and not equipped with the COVID-19 treatment facilities. And there was a fear among the doctors and the staff. And there was also when they started taking up the patient, there was unregulated pricing. So how the capacity building was done? ICMR along with the ministry onboarded certified private labs for the COVID testing, and the COVID portal was created, where there was regular entry of all the tests that were done, including the positive patients, so that surveillance can be done. And your rapid platforms like Gene Expert and TrueNANS were approved for COVID testing, so that a small private lab can also run the facility for diagnostics. There was real-time data sharing on the COVID portal. So this helped in tracking, surveillance, and your isolation. And there was a participation in quality assurance program, and your INSACOG, that is a genomic sequencing of the positive samples, through which we got an idea about the Omicron or your Delta strains. And later on, more and more private setup were able to run the COVID facility. Yes, government stepped in for providing rate capping, oxygen backup, and the regulated medicine, so that all patients we have a major segment of population in our country, so that they were able to take treatment even in the private hospital. And vaccination drive was another success story. Like private hospitals were also allowed to give COVID vaccines, and there was a COVID portal, and various vaccine options were available in the private hospitals like Sputnik, Covishield, and Covaxin. Now, some of the private hospitals came up with the state-of-art facilities like ECMO and the lung transplant. Obviously, these methods and these techniques are very costly affairs, but those who were able to afford and those who were eligible for these treatment, some of them was able to survive. Now, as we all know, we are discussing about the lung day and your lung tuberculosis and your tobacco programs. We all know that lung cancers are increasing, and
as you see that the chronic respiratory disease is the second number after your ischemic heart disease. And now there are more and more fungal infections that are cropping up, especially the respiratory fungal infection, chronic pulmonary aspergillosis, which is related to a post tuberculosis or your post COPD and post lung chronic lung disease, is a new entity which has now taken attention. And this is a very beautiful paper which has shown the burden for this disease. And this disease is actually a neglected disease, but it is a public health problem. And apart from the CPA, there are other lung infections, fungal lung infections that are cropping in. So respiratory fungal infections are common in diabetes, asthmatics, and chronic lung disease. And private sectors are equipped with all latest diagnostics and treatment. Post-mucor outbreak, advanced mycology laboratories has been set up in all various parts of the country, but still more to go. And since most of the patients coming in the privates are diabetics and asthmatic, they seek their treatment from private providers. So the doctors who are equipped with diagnosing and know more about the respiratory fungal infections are able to pick such kinds of infections. Now we have another challenge of AMR in our country. So there is a sustained rise in antimicrobial resistance in India. This is an ICMR study. India is facing a pandemic of antibiotic resistant superbugs, or it is a global health emergency. How this is related to the your lung health? Because as you know that there are respiratory viral illnesses. Now, when the patient comes with the respiratory viral illnesses, all doctors are in hurry to provide antibiotics, whether it is required or not. And there are your pneumonia cases and your severe pneumonia cases which are going on the mechanical ventilation, and they are being treated with inappropriate or injudicious use of antibiotics. So antibiotic resistance is not only a medical problem, it is
Hello.
the shopkeeper presented that sitar to him. So we don't have time to pura gana. I just want to make 10 points. First, in any public forum, I express my gratitude. So gratitude to you, Sajna and Anil, for hosting this program. Gratitude to the people working in defense forces. Toto, we sleep at night peacefully because they're awake at night. Gratitude to anybody from defense forces? And gratitude to COVID-19 warriors. First wave, 700 doctors mar gaye. Second wave, 750. So let's not forget it. This is always, whenever I go to any public meeting, I say this gratitude. Now, the second thing is research to policy to program. I've done a course on this at McMaster University in 1990 and 91. So we are all researchers here. But translate that research into a language which policymakers understand is very vital. And this subject, I doubt whether it's taught anywhere. If not, तो हमको शुरू करना पड़ेगा. Anil, language with policymakers. I have a lot of examples in my life to give that examples. Third point is COVID-19 and new viruses are here to stay. Please accept that as a reality. In that circumstances, you have to pay more attention to positive health. Positive health. And health and wellness ki jo expand kiya hai. Wellness has 8 components: physical health, mental, social, intellectual, spiritual, environmental, economic. So the definition of health is widened from the traditional World Health Organization definition, which was given in 1948. Now, Sunil, I don't know, there is a very frightening resolution passed by the WHO. I'm reading it. The WHO has drafted the pandemic treaty. Are you aware of it? If passed, it will be the first legal binding treaty that issues legislative powers to impose lockdowns, vaccine passports, and quarantines on its member states. Very serious. Acting as an international authority rather than an advisory organization. Metamorphic change. Right now, they're only advising. Now they got an authority. Very frightening. Now, what the policymakers, I'll just tell you a joke. A centipede had arthritis, and he had it in all his 100 legs. So you can imagine his quality of life. Arthritis, 100 legs, quality of life miserable. So somebody said, you go to the wise owl of the jungle. He seems to have answers to all the questions in this world. The owl thought for a moment, I've been all over the places. I've been to the All India Institute of Medical Sciences, New Delhi. High quality, affordable cost, homeopathy, naturopathy, sabhi jagah gaya. So when he posed this question to the owl, he thought for a moment, owl, why is owl? He said, the answer to your question is very simple. You are an owl, you are a centipede. All that you have to do is become a man. She got very excited. He went home and told his wife that today I got the answer to my health problem. Like all wives who are very pragmatic, she said, You are a centipede. How are you going to become a man? Oh, I am sorry. I forgot to ask him in their excitement. Now, Owl had a condition. You could ask him the question only once. उसने बोला अगले दिन चला गया. He pleaded कि मुझे और एक मौका दे. So, you know what the owl said? I am a policymaker. It is your job to implement the decision. So, here are the policymaker. Implementation is left to us. Now, in implementation, I saw in the discussions, one important thing came very, very, very prominently. You mentioned it. Communication for change in behavior. Very difficult. Early morning, somebody said this comment. Changing behavior is like moving the gravestone. Impossible. And for understanding to change in behavior, actually my daughter, Loto, she has done a course from Harvard, Master of Science in Communication for Behavioral Change. You require 5 disciplines: anthropology, sociology, economics, political science, and anthropology. And philosophy. How many of us have learned this during MBBS here? Isn't it? Nobody. 1996, Loto, I was a member secretary of the National Rural Health Mission, which was addressing the question of reforms in medical education. 1996 ki baat hai. That report is gathering dust somewhere. 96 plus 20, 27 saal ho gaye. So this has to be emphasized. Now, when you look at the cigarette companies who sell it are excellent in marketing. That's why, in spite of all the things you know, he said you have a cancer of the chest, lung, and still you smoke. You can imagine the convincing authority or strategy of the companies that sell cigarettes. So, उसको ध्यान में रखिए. My final words of wisdom. The topic that you mentioned to me is going to be just transmission of information. I want to leave with some thinking. Recently, there's very interesting books coming. Now, this is a book by Lisa Rankin. Mind over medicine. Mind over medicine. Scientific proof that you can heal yourself. And I must tell you that I have practiced. I have Parkinson's disease. I have Parkinsonism. And I have cured 90% of my Parkinsonism. I have cured it by treating myself. Now, what are the principles? My last statement. Believe that healing is possible. Believe that healing is possible. Number 2, connect and surrender to your inner light. थोड़ा सा philosophical है in the Indian philosophy. And surround yourself with healing support. Here the family becomes very important. Diagnose the root cause of your illness. Root cause analysis कोई नहीं करता. Superficial. Number 5, write the prescription yourself. Number 6, treat your fears and resistance. I end with Swami Vivekananda said, to make all this happen, look, you must have read that book, Swamiji Ka. Believe in yourself. Believe in yourself. Thank you so much for this opportunity. Thank you.
Thank you so much, Dr. Pandav. And now we move towards the last speaker of the day. We have with us Dr. Bharat Gopal, Director and Head Department of Pulmonology, Critical Care and Sleep Medicine, Delhi Heart and Lung Institute. We'll be talking about tobacco control and the moved approaches to addiction control. Dr. Bharat Gopal is the Director and Head Department of Pulmonology, Critical Care and Sleep Medicine, Delhi Heart and Lung Institute. He is a recipient of the Young Scientist Award from the National College of Chest Physicians, India, and has been awarded the Fellowship of the American College of Chest Physicians, USA. He has written several papers on respiratory diseases and has been instrumental in setting the Department of Pulmonology in many leading hospitals of Delhi. Dr. Gopal will discuss tobacco control and the novel approaches to addiction control.
Thank you. Are we going to have the slides or it is not possible? This is the last presentation. Even if it doesn't go on the Zoom, I think it's fine. The people here can benefit. Will it be possible? Just put it on then I'll tell you. I have put it in the minimize, just put it on and put it on the. Yeah. So I think being the last speaker, there is a responsibility that I don't stand between you and the lunch, but also have the free hand of actually speaking as much as I want because there is no one to follow me. So I think I'll see how it works. If you're not hungry, then you can keep listening to me. So I thank Policy Circle. I think it's been a year since since I attended your last meeting, and it's always a pleasure to come back. You have these, I think we wrote down all the minutes last time, and I believe it was quite useful. So 25th is the World Lung Health Day. So it's something which is actually quite new. So we used to have COPD days, and it's now gone into Lung Day. And I think things have become more in limelight for a pulmonologist after COVID. Unfortunate, but truth. We never had such social acceptance before COVID. So we were called as TB doctors. And so suddenly we became COVID doctors, and everybody from my whole clan would be after me that get me a bed in the second. So jokes apart, it was a sad time, but we never knew that we would get some sort of social acceptance this way. So this I speak on behalf of most of the pulmonologists in the country. So I am Dr. Bharat. I head the institute at Delhi Heart and Lung. And I'll try and in the next 8 to 10 minutes talk about the novel approaches to tobacco addiction control. So I think a lot of things have been spoken, and some of them will be just reiterations. But if you look at this 2021 Global Tobacco Epidemic Report, I think they should have actually labeled this as the pandemic report, because COVID has come and fingers crossed has gone, but the tobacco use would still looks like a pandemic which is in progress. We all have spoken. We are people who are involved in policy making. Unfortunately, we still have over 1 billion smokers worldwide. We have over 6 million deaths annually somehow attributed to tobacco use of various systems, not only respiratory. It is recognized that it's one of the most important cause of avoidable premature mortality. So that is the catchword. This is something which is avoidable, right? The pandemic came and swept across populations globally. Unfortunately, more or less was unavoidable. These are things which happen once in a century. But these things which we are getting used to and addicted probably are preventable. It's addictive, it's lethal. Half of all lifelong smokers die a direct consequence of their smoking. Unfortunately, we still, even as doctors, we don't still understand that nicotine dependence is a relapsing condition. since the doctors don't understand, we are not able to pass it on to the public, that let's not think it as a habit. Think it as a relapsing dependence. So once we start looking at, the policymakers will listen to us, and then only we will be able to get. So we will not get into the other aspect of why policymakers, unfortunately, do not want to look into or want to look the other way when we come to talk about smoking, when everybody knows how harmful it is. So at an individual level, the most tobacco users actually want to quit. That's a surprising thing. But they are unable to do it because clinically they are addicted to the substance. So that's why, if you understand that it's a chronic relapsing condition as say an arthritis, right? So you'll seek help. People who have this think of it as a habit, so they will not seek medical help for getting over this addiction, right? So I think those are the important points. So a smoker is almost like playing a Russian roulette, if you understand. So he's trying to shoot and he doesn't know ki kis khane mein goli hai. So he is smoking every day. He's losing years of his life, 16 to be precise, once he keeps smoking every day. These are the effective control measures which we all have seen. You monitor, you protect people from abuse of tobacco, from tobacco smoke, offer help to them, warn them about dangers, as ma'am said, probably right, stop smoking, enforce bans as we are doing on certain harm reduction methods, raise taxes. But has this actually helped over the years? It has not. So tobacco addiction continues to be a problem. Lung cancer continues to be one of the most common cause of cancer deaths. And though safe and effective pharmacotherapies and behavioral treatments are available, unfortunately, people do not quit smoking. And this is despite the fact that if you look at this study, this is an old study, but it still holds true. Almost 68% of people are interested in quitting. That's a huge number. 7 out of 10 want to quit. Only 5 attempt, and only say 7%. So 7 out of 100. So there's less than 1 would actually stay quit. So those are the numbers. They want to quit, they can't quit. They can't succeed. It is because of the dependence as a substance. It could be with other substances, but we are talking about nicotine. The Indian scenario is we are the second largest producer and consumers also of the. I would be very happy if we still, I'm sorry, but we are the second largest producer. Let's get off the second part where we not only produce it, but we also consume this toxin. So that's the bad part. This was a GATS survey 2017. Again, figures. I think figures make more impact in a policy meeting. So just look at it. Almost 30% of our population uses tobacco in smoke or smokeless form. And despite, again, as I said, most of the people want to try. This survey said almost 30% want to try. The percentage actually remains very low. And you look at somewhere between 10% if you make both the smoking and the non-smoking tobacco as one, between 6 to 16%. So let's take a benchmark of 10%. So again, about 1 in 100 will act, 10% is like 10 in 100, or 1 in 10 would actually will be sustained quitter. So that is the problem. So what we can do, I'm a clinical pulmonologist, so I'm not a community medicine specialist. I'm not a policymaker. So whenever I speak at such forums, I speak because I see the end point of these things. I have coming here, I had to go and take my round because my ICU is still full. We are not into the winters yet. My ICU is still full of COPD patients, all of them because of smoking. I do a lot of interventions. I do lung biopsies. We are seeing lung biopsies positive for cancer in females who are 40, 42. And the one thing which is going to be common is that these are people who are smokers. Let's not put everything on pollution. There is a definite increase in number of female smokers in India, especially in metros, right? And that is the reason that we have been around 20 years back when I started, one of the first people to start bronchoscopies in Delhi. I could not believe when I had a female who was 36. I still remember 36. And I was thinking that this is a mass, maybe some benign hematoma or something. came out to be adenocarcinoma, and it was impossible. They could not believe a well-off family, and they just could not believe. But they were even at that time into having parties and smoking, traveling abroad. So this is a challenge. The psychosocial approach, which we all know is 5 A's: ask, advise, assess, assist, and arrange. This everybody knows. Why I bring into a presentation which is titled as Novel Approaches to Tobacco Control? Because I still feel this is novel because we don't use it. Novel things are ones which are new. Am I right? We have young people. So I think a lot of you are from community medicine background. I am so surprised that even in our consults as physicians, we hardly actually spend time on, so maybe a passing remark of by a cardiologist, "Arey, don't smoke, nahi to ek aur stent lag jayega." So we don't have to be judgmental. Maybe I would be accused of sometimes doing it to my patient, ki tum mante hi nahi ho, har baar admit ho jate, and you go back and you think everybody, every time me or the God can actually combine to send you back from the ICU. So I feel that the advices, the assessment, the assistance to these individuals who are looking to quit is very, very important. Nicotine versus nicotine. This somebody brought up, I think Dr. Harper's talk. So it's almost like Karthik calling Karthik, you know. So we have a whole continuum of products which are nicotine, and maybe the worst or the most nicotine containing is going to be cigarettes. And as we go down, it would be something like a nicotine replacement therapies, which we use as doctors, but they have nicotine, right? So he was right that nicotine is not the problem, but nicotine is a problem because it is the dependence part. So you need to somehow take care of the dependence, because I have taken many talks on harm reduction, even in this hall, and I've been a supporter of harm reduction but I am a supporter of harm reduction, not for the community, but for my patients. I have been always very, very clear that these are things which we can introduce into the system for patients who are already suffering from COPD, people who have lung cancers. We don't want to make them keep smoking. And if they want to quit, they can't quit. We can at least reduce the risk. I am not like going into the community and saying, okay, you are a healthy individual, because I'm not sure that is India still prepared to take that responsibility to choose between less harm and more harm, right? I'm not sure. So I don't know, we have seniors here. So this is the continuum. Nicotine replacement therapies are not novel. They're underrated. They're underutilized. I think this is something which we can, they're not expensive. So these are now well approved by all medical councils and bodies across as part of the cessation programs. But what is novel? I think novel is that we have drugs available, right? Novel is that we can use combination therapies of a drug with nicotine substance. That is novel. This whole chart is available since last 10 years. But we have novel delivery systems. So there are people who don't want to probably chew a cigarette, or we do not have availability of lozenges. So you can have nicotine inhalers, nicotine nasal sprays to actually substitute the nicotine so that you can then gradually reduce the dependence, right? So that is another thing. E-cigarettes, very controversial. So I'm not going to debate. I can debate for 2 hours, but so this is approved in US as a part of smoking cessation programs. There is data available in reputed journals. It has to be critically analyzed to where they have actually done it. So let's not put it at a community level still, because if you have, say, 3,000 individuals being screened, it is too small a number when you have 1 billion smokers. So, but you have data which is very clear, published in even in the journals like JAMA and NEJM, where they say that odds of quitting cigarette smoke are more if you convert to e-cigarette. So this is a novel method in people who cannot quit smoking, not the first method. Again, even compared to NRTs, this is published in NEJM, that's mother of all journals. So They actually looked at a year-long cessation, and they found that if you compare both products give equal behavioral therapy, the chances of 1 year abstinence are more with e-cigarettes. So what are the innovations? We have conquered the moon. We are almost thinking of now conquering the sun. So I think it's time that we can actually spend some time on conquering something which is a century old. No, we चांद तक तो पहुंच गए, घर पे तो हमने कुछ भी नहीं किया. So I think these are things that we have, ma'am, who has been my teacher, but I think as part of you are part of the government. So these are things which we need to. I know a lot of things are being done, but probably newer, innovative methods to be looked. So quit lines have been set up. I know my alma mater, Patel Chest, has a tobacco quit line. Digital platforms are available across the globe, like Smoke Free, which contains information, modules, and crisis intervention strategies. But let's quickly look at smartphone applications. We all use smartphones. We are a digital India, right? My son is at IIM Bangalore. He says he comes to Delhi. He said, Delhi to bahut piche hai. In Bangalore, they say, even the rickshaw wala says, no cash, give me Paytm. So that's the level of digitalization which has reached. If it has reached one city, it would reach across the globe, right? We can use this. There are WHO last year launched an app for tobacco quitting, right? So these are apps which give you real-time support, feedback. They track your progress. They offer encouragement. Sometimes they deliver strategies if you have cravings. So these are various. You can actually, if any, I'm not asking for a show of hand. If any of you smoke and you want to quit, you can go to these. These are on the Play Stores or on the Apple Play Stores, and you can actually download and use this. Text messaging programs, right? So CDC actually sends you text messages if you are involved with their quit smoking. They will give you programs where they will give you messages of encouragement. You can actually send a SOS messages if you are having craving. Somebody will call you. They will probably give you support, tell you how to go over that situation. So that's, I think, a very, very easy aspect of sending SMSs. I still feel, ma'am, we get so many SMSs about so many things, right? This is not a difficult or expensive thing. This should be one of the take homes that the government should, we a few days back, we got that big chunk of emergency message. Did you see, Lottie? Yeah. So we can have that type of a wired message to all if that don't smoke, and if you smoke, this is our helpline. I think let people be partners in, and you cannot force. I've been a pulmonologist for last 25 years. You cannot force people. Sometimes they say, "Yaar, main to bata hi sakta hu." So but that's the helplessness as a doctor, because it is tough. When you get addicted to anything, it is tough. Virtual reality. Wonderful innovations. I think this is something which again we can use. You have these virtual realities. These are available internationally. I think they can be we are a IT savvy country. We can get these. These are where you can actually create situations. So you are using a virtual headset. You will be into a situation like you are in a party and you are the 10 of your friends who are smoking, and you will get the craving because you are in almost in the virtual world. Now with that, you will be taught how to manage. So when you actually go to a party where 20 of your friends are smoking, you are already, you know how to actually go over those cravings. So you have these, there is a program called as Mind Content where they actually make you go from smaller to larger craving situations and how you actually manage. And this is not, I'm not talking from the internet. These are research-based evidences. So you have papers published in a journal like Annals of Medicine where augmented reality has been probably tried as a smoke cessation. Then in 2023, the catchword is AI and ML, right? So artificial intelligence and machine learning, you can actually create situations and actually create how a particular individual can actually be motivated, right? So this is like personalized program for smoking cessation, because one size may not fit all. Not only, again, this is a PATH study which was published last year. Not only this, the University of Pennsylvania, the Penn School of Medicine actually went back and looked at almost 1.3 million people and their smoking habits and the drugs which they're using, and they found that 8 medications actually could be repurposed. So you don't need new medicines. A simple drug like dextromethorphan, it's in most of your cough syrups. And there are drugs for Alzheimer's. These can be actually repurposed to actually take care of the cravings. Then games. You have a simple game. I was saying you can go, and what it does is you have to just, you remember that that the fruit ninja. Has anybody played? Only one girl, no? 3, 4. So instead of cutting that fruit, you're cutting the cigarette, right? So it gives you that, okay, I want to quit. So this is, so you have numerous number of such situational gamings available. So I think that is time well spent rather than on online gamings. And I think this is something which I felt when I was trying to look at what, when Sajna gave me this topic. So yesterday evening when I was trying to look, I said, I think this is something which we all wear smartwatches now. We hardly utilize 2% of the facilities which we have on a smartwatch, apart from it looking smart. We hardly use anything. So you can, there are bands available, which because of our physiological changes, so the heart rate, when you have craving, your heart rate will change, right? Your SpO2s may change. So you can have those type of things. It actually will trigger an alarm on your phone or on, say, vibrate, that you are having craving, right? So you need to take action. Or you can actually have a timed app which will tell you, okay, you need nicotine substitution every 6 hours. Because if you don't take it every 6 hours, this 6 hours, 30 minutes, you will get the craving and you may then land up going back to the cigarette. So you can have the, I don't know if you can have this type of a trigger into your phone where you can do. And again, published literature. So this is not just a smart IT guy coming up with a funding type of a app. These are proven published literatures which are available. And telemedicine, I think this is again one of the boons which occurred post-COVID. And it's been very helpful to a lot of my patients, because we used to, when you practice tertiary care, so a lot of patients come from outside Delhi, 300 kilometers, 400 kilometers. And I think it's been a very big boon, because we are not legally allowed to do telemedicine. So they save on the travel. A lot of them just want follow-ups, just few tweaking of the medications. So I think, and this has been used, published literature in COVID, people who were onto the programs of smoking cessation, they actually utilized telemedicine. And now you have newer apps and newer software development where you can have chatbots. You can just say, okay, I'm having craving. You will get automatic messages, or then some counselor will come back to you and make you tide over that crisis, which may not be actually possible. You can't just run to a clinic or to Patel Chest. Saturday, Sunday it is closed. Then you will have Saturday, Sunday, you'll smoke and you'll say, I'm sorry, you were not there. So I think this is a good way. So finally, future research is occurring. Don't be disheartened, young guys and girls. We have monoclonal antibodies to block the receptors which give you pleasure with nicotine. So that is going to be something. One very new thing which is being tried is something called as transcranial stimulation. So you stimulate precortex of your brain, which will not give you that good feeling of, see, everything is about the, we have not touched, I think you all know, it's the pleasure. And the dopamine, it gives you the pleasure at that, okay, this thing is very nice. So it's, then you can use their drug trials for a few drugs which are occurring. This is a huge list which I downloaded yesterday of. So future is not bleak. We need to reduce mortality and morbidity in these smokers, especially those who are unable to quit. We have to prevent newer generation from getting addicted. So that is also a very, very big challenge. Fighting tobacco is a team effort. We are all here from different facets of medical profession and non-medical profession. But I think whatever we have done, it is minuscule. We need a lot of effort, a lot of progress is still needed. We have in a couple of days, the World Lung Day. So a lot of it is because with Forum of International Respiratory Societies, our society, the FCRD, is also part of it, and we'll be doing few programs over the next week. And I think I'm pretty sure that as I extended the time, but that was the privilege I got by speaking last. So you can follow on the various social handles. I keep putting something to do with medical science only. So, and thank you so much.
Thank you so much, Dr. Bharat Gopal. I think it was one of the most interesting presentations that we've had today, and some very tangible and doable suggestions that you have suggested. And I'm Dr. Sunila Garg is here. I'm sure she'll have a lot of points to take back home. Well, before I ask her to give her concluding remarks, does anybody have any question for the panelists here? They'll be happy to answer. If you keep your questions pointed and to the point and very brief, so I think they'd be happy to answer them. There's somebody there? Okay, please. Yeah, please use the mic in front of you. Just walk up to this mic and just press that button. Yeah. Tell us your name. Where are you from?
Hello everyone. I'm Anushka Saini. I'm a second year MBBS student from Maulana Azad Medical College. Sir, I'm glad that you brought this up again, because I had several questions during that earlier presentation by Dr. Peter from England. So I felt that there was no mention of cigarette versus smokeless tobacco risks when weighted for addiction potential, because e-cigarettes are after all filtered nicotine, right? So they could have more addiction potential. And whether it would be introduction of e-cigarettes into the community would increase total consumption of tobacco in individual people.
So you want me to speak more? That's fine. So
briefly,
I'll tell you, when I was touching that e-cigarette 2 slides, I said that I can speak for 2 hours. So you don't have time that much. I need to go back to the hospital. In short, there is data to show it is not a gateway to new smokers. Enough data. There is data to show it is not more addictive. The numbers of smokers in the countries where e-cigarettes have been introduced are not more than what they were prior to the introduction. So that shows there are not new smokers. So the addiction potential. The problem why we banned it in India is because we felt that the biggest thing which they wrote in the white paper was that it could be a gateway to new smokers, especially young children. So I will not give my take on it. There is no point. This is not the forum for that. But I think rest assured, it is not going to lead to more things. And to tell you, it is so expensive. It is so expensive. I cannot believe it coming into the community in next many years, right? But I still feel it has a potential to be used in a program, in a proper designated, authorized, prescription-based program, only for people where you have run out of all the other ways of quitting, right? You have those 5 A's, so psychological support, drugs, nicotine replacements. You still cannot quit, then you do the harm reduction. It is a harm reduction method for us, right? So I think, I hope that answers the question. So
yeah. Anybody else? Yeah, okay.
So it's something that actually you said.
What's your name?
Oh, sorry. So I am Dr. Joseph. I'm first year postgraduate student from Maulana Azad Community Medicine.
Right.
So it's something actually you said that kind of like clicked. You said that numbers mean more to policymakers, right? So since my childhood, I've been seeing ads for tobacco quitting or smoking in theaters, multimedia ads, and that has been going on. Most of the things are same. Can't numbers also be included so that the public gets an idea how much it is getting?
No, but I believe that the type of that 10-15, it's a big documentary now before the any movie. So it's almost like a 10-minute show, and the way they show it is pretty horrifying already. If you don't need 5 of those things which they show are worth probably giving you a data of 1 million people smoke and 70 get it. I don't have bad luck. Those are really horrifying. Whoever has, a lot of you will know, whoever has probably made that. Sometimes you go and you feel, yeah, come on, movie dekhna hai, kya dikha rahe hain? But I think it hits where it has to. The bigger problem why I use that statement is that policymakers understand numbers is because when you do anything as a part of policy, it has to be extrapolated into what is the utilization, because there's a cost involved with everything, right? So that challenge can only be met once you are. So don't take me otherwise. It is a truth. If I have to even buy a machine in a corporate hospital, I have to give something called as an ROI. So 10 years, 15 years back, before I joined corporate world, I had no clue what an ROI is. So in my first interaction with them, they do call it interview over coffee. They would say, "Oh, so what, doctor, tell me what is the ROI?" So I was saying, what is ROI? So I couldn't, because I was working in a charitable hospital. So everything was what you won't bother if you earn or you do not. So that's how things change. And government also needs, ultimately, it's our taxpayers' money. So numbers are important. You cannot spend your time, ma'am's time, everybody's time on things which are not going to be useful at public level. That's why e-cigarette was banned, because they probably realized, in even if they did not publish, that the amount of money and the amount of effort which is going to be required to regulate it in the community is going to be enormous in terms of the manpower.
Okay, any more questions quickly? Yes. Okay, two more questions after this, and then we're all hungry actually.
Hello, ma'am. I am Harshvardhan, second year MBBS student from Maulana Azad Medical College. So my question is from Chavi ma'am and Sunila ma'am. Ma'am, like you said about adult vaccination, and ma'am, you said that in children below 5 years of age, pneumonia is one of the most common causes of death. So, ma'am, I was just asking that the way we have included Haemophilus influenza subtype B into the pentavalent vaccination scheme, should we also include the vaccines like PCV7 and PPV and other vaccines for pneumococcal infections?
Yeah.
Was not included in the childhood immunization program. It was only adult immunization program. So the guidelines which are available, how to vaccinate and how to do, are based on that data. And now they have included in their childhood immunization. So earlier it was two vaccine, that is PCV 13 and PSV 23, followed by a booster, because they were used in adult. Now they are using it as a childhood immunization, that is PCV. In India, still it is not available in childhood immunization. So actually the doctors become confused when they read international guidelines and what to give, because as US introduced it in their childhood immunization, they removed that booster, because that is not more required now, because they are using it in childhood immunization. But in India, we are not using it in a childhood immunization. We are still using it in adult population. So we have to follow the old guidelines. So first of all, we should remember this concept. And secondly, regarding this, yes, it is should be introduced in their childhood program, immunization program. Lot of surveillance is being going on pneumococcal diseases at various levels, at a microbiology level, and maybe probably they can come up with the idea of introducing it in a childhood program. But still, all vaccines which has been included in the public health program are the vaccine that are of some public health challenge. It has not yet become a, I think, public health challenge. That's why ma'am will give a
Definitely,
better
we
answer.
are, moving towards that. And another part is, all of you remember that recent addition to the whole thing is also HPV vaccine.
Yes.
So we are moving towards from the public health perspective, but all of us have to read about integrated management of neonatal and childhood illnesses, which is also major concept, which is involving frontline workers, because all of us has again and again being told by Dr. Bharat that he is, busy and all that. Doctors don't have that much of time. So we have to empower our frontline workers. So somewhere in the newer strategies, I feel that it is such a, and we've been talking about, and policy circle has been talking about the different initiatives. We have to reach the last mile. And how do we reach the last mile? We have got 1,62,000 health and wellness centers. Though we are in different phases of implementation, we cannot reach the last mile without involving them. So that is important. So that part we have to remember that, and we have to implement all the national programs in that perspective also. And RMNCHA is the right step in that direction, where, reproductive mother, child, newborn child, and all the adolescents. So all these are part of that. So we have to go in an integrated manner. And Chavi already pointed out about the role of adult vaccination, but we have already HIV vaccine also. So we have to remember H influenza B. So that part we have to take into consideration. So we are, looking from a public health perspective, and we are working simultaneously on both the newer vaccines which are there in the pipeline for both the children and adults. We have to see that how cost effective it is. But most important part is that we have to address the whole issue of why do we get these pneumonias and all that. It's not because of the burden of the disease. We have large chunk of malnutrition as well, which makes the children more susceptible. So that is another important thing which we need to keep in mind. So
I think we're already running late
Yeah.
by 1 hour, so we'll have to cut down on the
I'll
questions.
cut down,
And yes,
yeah.
ma'am, your concluding remarks,
So,
please.
I think first of all, thank you, Sajna. Thank you, the policy circle and the, whole team behind the whole thing. It's not one person who can organize. We've been working since long, and I really feel that it is so very important that we carry on this discussions forward towards health system strengthening. And we had some very beautiful sessions by Dr. Madan Gopal, the role of the government. Aparna talked about, the latest scientific achievements that showed that if India wants to do, India can do it in faster mode, faster approvals. We were one during that time when there was international research. Chavi really talked about, so much of out-of-pocket expenditure is there. So that there comes the role of private providers and all that. And few days back, I had met Dr. Pawan Gupta, who is also maxillofacial, this thing also, and he works with eye care, and that's his passion, about tobacco cessation. And I think
he was here last year,
yeah.
right?
And we need to also, we learned a lot of things from Peter Harper, that is where he talked about the harm reduction, but we have to really debate whether there's harm reduction or not. Because these, let me tell you from my experience, pharma companies are very strong, very, we have been dealing since long with FSSAI with regard to front of package labeling. हम सोचते उसमें क्या है? आप लेबल पे डालो ना, हाई फैट है, सॉल्ट है, शुगर है, कैलोरीज है, क्यों नहीं डालते वो? This is, I'm talking of one thing. बस 2 मिनट मैगी, बस चिप्स आ जाएंगे. So this is where we need to be cautious, and we need to be cautious about the publications also. There's a publication bias which we need to also look at it very, very carefully. Another important thing is all of you are aware of sustainable development goals, which we need to, if we are talking of, I'll talk of 7 goals which are directly impacted by tobacco. We will not be able to achieve no poverty if we are indulging in tobacco. We will not be able to achieve zero hunger. Again, tobacco is going to be responsible. Health, all components of health are going to be affected. Then quality education. That is also one of the sustainable development goals. If families are indulging in tobacco and all that, where comes the issue of sending children to school? Because India is a big country. If we talk in that context, that is important. Gender equality, and another part is also reduce inequalities across the world between different geographies. Because now, also Dr. Gopal pointed out one thing was that, now the pharma company, tobacco companies are aiming at targeting the females. So that is where we need to kind of empower our females with the correct knowledge, both males and females. There's no gender bias, but especially when you have to see who is more vulnerable to these media ads and all that. That's one, very important. One day, I remember one of my husband is a pediatrician, so one lady came to her because of her one baby she has got, and she was, pregnant for the second time, and she said, "Doctor साहब, आप सब कुछ बताइए, मुझे ये मत बोलिए कि मुझे सिगरेट छोड़नी है." We know the direct impact of the low birth weight baby hoga, placental insufficiency hoga, but somewhere we have to come out with the innovations, and we have to be straight upfront with regard to that. Another thing is that we need to look at, when we are looking at sustainable cities, how the cities are going to be sustainable when we are going to talk about pollutions and different issues. So we have had a wonderful discussion, and I still remember those points of achar, vichar, ahar, vihar, and vyavhar. So these points which were raised by, by the first speaker, Dr. Mishra. So it has been a wonderful session, and thank you, Lottie, for excellent, being the master of ceremonies, and thank you, all of you. That's where I think, and thank you all the students. I'm sure that there would be a lot of learning, and you can pick up small problem-based exercises. And I thank the institutions as well for sparing, because it is not always possible to get them. So that's where I feel that, but then when you go and present what you learned over here, so that will make and give us a short report from your side also, so that we can see that what has been your understanding. So thank you, everyone. And it's been really interesting and wonderful. And I really enjoyed it personally, and a lot of learning from it.
Thank you so much for your concluding remarks, Dr. Sunita. I think this has been a really fruitful session that we've had today. some very interesting discussions, points to be pondered, and I'm sure there'll be a lot that you all will be able to take home. And again, thank you to the students, particularly for coming. और वो जो homework मिला है वो कर लेना सब लोग, है ना? और and thanks to Policy Circle first of all for organizing such an event. And I think these are the things that need to be debated. They need to be spoken about because policymakers also do need to know what is going to be feasible, what is going to be workable and not. So I think these things should be out in the open and people should be discussing this more. Thank you for giving me this opportunity, Sajna and Anil. So I will be signing off now. Thank you so much till we all meet again.
Who is going to announce for lunch?